before. Congratulations. 다음 장 끝인가요? I'd like to heartily congratulate all
이때
the
원장님
winners.
잡아주세요.
I hope
원장님.
those selected research outcomes will continue to strengthening solid foundation for further study in clinical practice. Congratulations again with big applause. Thank you. Thank you very much. My sincere congratulations for all the awardees. The award and gifts will be delivered by mail safely.
네네.
The next award is the Rising Researcher in Korean Medicine Award. We have chosen 2 researchers, and the President Choi Do-young from Society of Korean Medicine will honor the first awardee. Please welcome President Choi.
영상 끝까지 한번 볼게요. 오디오 열어주세요.
축하드립니다. 한국한의학연구원과 대한한의학회가 공동으로 마련한 한의학 신진 연구자상을 시상하게 되어 매우 뜻깊고 의미 있다고 생각을 합니다. 이번 신진 연구자상이 한의계의 발전을 위해 열심히 연구하시는 젊은 연구자분들에게 많은 도움이 될 것입니다. 한의학 신진 연구자상의 첫 번째 수상자는 대한친구의학회 소속인 김민정 교수입니다. 축하드립니다. 김민정 교수님은 친구 분야 임상연구및 각종 표준화 연구에 뛰어난 연구 역량을 보유하고 있으며 활발한 연구 활동을 통해 관련 분야에 많은 기여를 하고 있습니다. 앞으로도 한의학의 발전을 위해 활발한 연구 활동 부탁드립니다. 김민정 교수님 수상을 다시 한번 축하드립니다. 감사합니다.
괜찮아요. 그러니까 아까 정도로만 지금 이분이 상 받는 거를 아까 영상에서 최도영 이 회장님이 말을 해주시는 거거든요. 그래서 그 영상을 다시 한번 그 부분만 틀어봐 주실래요? 네, 영상을 해서
성공적인 개최를
시상자 말하는 대로 가봐주세요.
한의학의 발전을 위해 한의학 신진 연구자상의 첫 번째 수상자는 대한친구의학회 소속인 김민정 교수입니다.
다시 한 번만 해볼게요.
한의학의 발전을 위해 열심히 연구하시는 젊은 연구자분들에게 수상자는 대한친구의학회 소속인 김민정 교수입니다. 축하드립니다. 김민정 교수님은 친구 분야 한의진 매우 뜻깊고 의미 있다고 생각을 합니다. 이번 신진 연구자상이 한의계의 발전을 위해 열심히 연구하시는 젊은 연구자분들에게 많은 도움이 될 것입니다. 한의학 신진 연구자상의 첫 번째 수상자는 대한친구의학회 소속인 김민정 교수입니다. 축하드립니다. 김민정 교수님은 친구 분야 임상연구 및 각종 표준화 연구에 뛰어난 연구 역량을 보유하고 있으며 활발한 연구 활동을 통해 관련 분야에 많은 기여를 하고 있습니다. 앞으로도 한의학의 발전을 위해 활발한 연구 활동 부탁드립니다. 김민정 교수님 수상을 다시 한번 축하드립니다. 감사합니다.
아니 중간에 말 나올 때 네 중간에 다시 한 번만 해볼게요. 그럼 다시.
안녕하십니까? 대한한의학회 회장 최도입니다. 먼저 키움 SAR 2020 성공적인 개최를 축하드립니다. 한국한의학연구원과 대한한의학회가 공동으로 마련한 한의학 신진 연구자상을 시상하게 되어 매우 뜻깊고 의미 있다고 생각을 합니다. 이번 신진 연구자상이 한의계의 발전을 위해 열심히 연구하시는 젊은 연구자분들에게 많은 도움이 될 것입니다. 한의학 신진 연구자상의 첫 번째 수상자는 대한친구의학회 소속인 김민정 교수입니다. 축하드립니다. 김민정 교수님은 친구 분야 임상연구 및 각종 표준화 연구에 뛰어난 연구 역량을 보유하고 있으며 활발한 연구 활동을 통해 관련 분야에 많은 기여를 하고 있습니다. 앞으로도 한의학의 발전을 위해 활발한 연구 활동 부탁드립니다. 있습니다. 김민정 교수님 수상을 다시 한번 축하드립니다. 감사합니다.
이때 LED는 풀화면으로 못 나와요? 나올 수 있죠? 어려워요. 이게 현장에서는 이렇게 나오는 게 좋을 것 같은데. 네. 네, 그 다음에 원장님 두 번째로 갈게요.
음악 좀 끝날 쯤에 시작하면 되죠?
네네.
네. Thank you very much. And now let me invite President Kim again for the second awardee.
그러면 이때 원장님이 다시 한번 올라오는 거거든요. 그래서 등단 음악 주셔야 돼요. 기억해 주세요. 이때 원장님께서 다시 한번 올라오세요. 감독님, 음향 감독님. 주세요. 사운드 주세요. 이거 안 맞아서 그런데 다시 한 번만 할게요. 원장님 소개하는 거.
Thank you very much. And now let me invite President Kim again for the second awardee.
왜 안 맞죠? 자꾸. 아니 수정 씨가 옆에서 알려주면 되잖아요. 지금 이 상황이 뭐냐면 앞에 최도영 회장님께서 시상자 한번 발표를 하셨잖아요. 그럼 지금 사회자분께서 그냥 여기서 뭐 이제 감사하다고 그런 다음 두 번째 시상을 위해서 지금 원장님이 다시 올라오는 상황이에요. 그냥 그것만 알고 계시면 되거든요. 그러니까 다시 한 번만 해주세요.
네. 영상 끝났고요. Thank you very much. And now let me invite President Kim again for the second awardee.
네, 이때 올라올 거예요. 올라오시다가 여기 앞에 주시면 여기 원장님 읽을 거 띄워주셔야죠. 네, 원장님 아까도 해주세요.
As you know,
하면
motivating young researchers is the essential in every academic field. 지금 음악은 빠져야 될 것 같아요.
빠져주세요.
And so Kiom Sar 2020 conference is the right place in motivating young Korean researchers. 뒤에만 할까요?
네네.
네.
여기요.
Okay. The second winner of the Rising Researcher in Korean Medicine Award is Dr. Im Jung-tae from
화면
the
주세요.
Society of Internal Korean Medicine.
임정태 화면 주세요. 네네.
Im Jung-tae from the
화면
Society for
넘겨주시고.
Internal Korean Medicine. 프롬프터요. Dr. Lim is a promising researcher who is substantially contributing to the establishment. 배경음악.
이때 배경음악 한 번 더 들어야 되고요. 원장님 얼굴 다시 한번 이렇게 좀 번갈아 가면서 보여주세요. 보람 실장님. 네, 그러면 지금 원장님께서까지 한 거거든요. 이거 안 되겠으니까 다시 처음부터 해볼게요. 처음부터 갈게요. 페이지 처음부터. 지금 플레이너리 세션 5가 끝난 거예요. 5 끝나고 이제 사회자님이 올라오신 거예요. 정리 다 되셨어요? 그럼 들어갑니다. 저희 시간 얼마 없어요. 해주세요.
네. Now that concludes the last plenary session. I would like to thank all the presenters and the chair. It's time
안녕하십니까?
for the closing ceremony of the Kiom SAR 2020 International Research Conference. Distinguished guests, ladies and gentlemen, good afternoon. I'm Harim Seo from Kiom, and I'm pleased to host this closing ceremony today. We had more than 2,000 participants from 56 different countries around the world for the Kiom SAR 2020, and I can say that this is unprecedented number. It is regrettable that we couldn't meet all the participants face-to-face due to this COVID pandemic. But I'd like to say that this year's conference was very innovative and successful for having this many participants, thanks to the internet and ICT technology. At this conference, in addition to the official programs, we have prepared a special program for Korean Medicine College students. I hope this program could help them to explore various future paths as the talented of the future of Korean medicine down the road. And now, I have
여기서 페이지 간지 주세요. 그냥 계속
And now
읽어주세요.
I have the honor of opening the official closing ceremony. The closing ceremony will
페이지
start
간지요.
from
여기서
the
페이지
award
간지 주셔야 돼요.
presentation, closing remarks, and the announcement for the 2021 SAR conference. First, 3 presenters will be awarded with outstanding oral presentation, and the Rising Researcher in
여기
Korean
아니에요.
Medicine Award will be given, which is a joint special award prepared by Kiom and the Society of Korean Medicine. Now,
여기서요.
it's time to announce the awardee who graced this conference with outstanding oral presentation. President Kim Jong-yeol of Kiom, the co-chair of this year's conference, will announce 3 awardees. Ladies and gentlemen, please welcome President Kim with a big round of applause.
원장님 거 첫 번째 거 주세요. 우수 연구자상 시상하는 거. 프롬프터 맞죠? 해주시면 안 돼요?
Good afternoon, I am Kim Jong-yeol, President of the Korea Institute of Oriental Medicine. I'm really amazed. I would like to amaze
왜 그래?
3
왜
days.
그래?
네, 다음 장. I'd like to express my sincere gratitude to all the fellow researchers who have energetically attended, presented, and discussed in the conference. More than 150 abstracts were submitted for the conference, and 11 abstracts were orally presented. Now it's time to honor the best outstanding presenters with awards. Among 11 oral presentations, the evaluation board chose a remarkable one in basic science and 2 outstanding ones in clinical science. Now, let me announce the winners of the awards of Kiom SAR 2020 on behalf of the organizing committee. First, the winner of Outstanding Senior Researcher Award in Basic Research is Dr. Harrison Fisher. He
밑에 주세요.
identified the role of brain connectivity in the
음향 감독님
effect of
밑에 주세요.
acupuncture in carpal tunnel syndrome. It has significant impact in acupuncture research. Congratulations. Next, the Outstanding Junior Researcher Award in Clinical Research goes to Choi Yu-jin. She presented the significant result of the pilot study on mild cognitive impairment and the comparative effect of electroacupuncture. Congratulations. Lastly, the winner for Outstanding Senior Researcher Award in Clinical Research is Dr. Lee Ye-sul. She conducted a systematic review on reporting of the placebo sham intervention in clinical trials of acupuncture. It has not been evaluated thoroughly before. Congratulations. I'd like to heartily congratulate all the winners. I hope those selected research outcomes will continue contribute to strengthening solid foundation for further study and clinical practice. Congratulations again with big applause.
네, 사회자님 잡아주셔야죠. 사회자님.
원장님 퇴장할 때는
원장님께서 지금 이거 하고 이때는 제가 저쪽에 있을 테니까 제가 사회자 드릴게요. 이때 원장님께서 한번 시상하고 내려가신 다음에 사회자님 멘트 할 거예요. 거기서 해주세요.
Thank you very much. My sincere congratulations for all the awardees. The award and gifts will be delivered by mail safely. The next award is the Rising Researcher in Korean Medicine Award. We have chosen 2 researchers, and the President Choi Do-young from Society of Korean Medicine will honor the first awardee. Please welcome President Choi.
네, 영상 주세요. 영상 좀 뒷부분으로 좀 가주세요. 시상 소개하는 부분.
안녕하십니까? 대학의학실 연구하시는 젊은 연구자분들에게 많은
시상
도움이 될
부분으로 좀
것입니다.
가주세요.
한의학 신진 연구자상의 첫 번째 수상자는 대한친구의학회 소속인 김민정 교수입니다. 축하드립니다. 김민정 교수님은 친구 분야 임상 연구 및 각종 표준화 연구에 뛰어난 연구
이때
역량을
최도영
보유하고
회장님
있으며
얼굴 번갈아가면서 좀
활발한
보여주세요.
연구 활동을 통해
다희 팀장님.
관련 분야에 많은 기여를 하고 있습니다. 앞으로도 한의학의 발전을 위해 활발한 연구 활동 부탁드립니다. 김민정 교수님 수상을 다시 한번 축하드립니다. 감사합니다.
Thank you very much. And now, let me invite President Kim again for the second awardee.
층단 음악 주세요. 네, 원장님 자리하셨습니다.
As you know, motivating young researchers is the essential in every academic field, and the conference takes
시상
place in
부분만
Korea.
할게요. 시상 부분으로 좀 넘어가 주세요.
네, the second winner of the Rising Researcher in Korean Medicine Award is Dr. Im Jung-tae from the Society of Internal Korean Medicine. Dr. Lim is a promising researcher who is substantially contributing to the establishment of scientific evidences for Korean medicine. 넘어갈게요. Implementation of clinical research. Congratulations on your award. I hope you will continue your efforts for the future of Korean medicine.
네,
Thank you. Congratulations to all the awardees once again.
죄송해요. 여기서 원장님 내려가십니다. 이거 알고 계셔 주세요. 죄송해요. 원장님
네.
계속 계시죠? 네, 네.
Now the President Kim will deliver the closing remarks. President Kim, please. Good afternoon, distinguished participants.
폐의사, 프롬프터에.
Kiom Sar 2020 has come to an end after 3 days of passionate presentation and hearty debates. 거의 뒷부분으로 넘겨주셔도 될 것 같아요.
폐의사는 굳이 저희가 그냥 마치기만 하면 되는 거죠. 그래서
네.
폐의사까지는 안
네.
해주셔야 될 것 같아요.
In the US, thank you very much.
네, 사회자님으로 한번 다시 가주시고요.
네, 원장님 다시 내려가세요. Thank you very much for your thoughtful words. Ladies and gentlemen, please give them a big round of applause. 이때 원장님 내려가시면 직원들 박수 좀 부탁드릴게요.
네, 네.
네. Next is closing remarks by Professor Richard Harris, the co-president of SAR, as well as the co-chair of the Kiom Sar 2020. He'll also make an announcement about the next year's SAR conference. Please welcome President Harris.
비디오 주세요.
Hello, this is Rick Harris. I'm one of the current co-presidents for the Society for Acupuncture Research. I want to welcome you to this concluding ceremony for the highly successful Kiom Sar 2020 meeting that was held here in South Korea. I hope you enjoyed the content of this meeting and that you've renewed bonds between your colleagues and friends, and maybe forged some new ones. As you know, the Society for Acupuncture Research holds many events, such as these, in the US and abroad. And I'd like to let you know that in 2021, the Society for Acupuncture Research will be holding another conference, this time in Ann Arbor, Michigan, from June 16th to June 20th. The title of this conference is going to be Pandemics, Pain, and Public Health, Roles and Relevance of Traditional East Asian Medicine. I hope very much that you'll be able to attend in person, but if you're not able to attend in person, I wanted to let you know that portions of our conference will be virtual, meaning that you'll be able to access portions of the conference from anywhere in the world. It also may be that we hold the entire conference virtual if COVID does not cooperate. Thank you very much for attending this conference, and I hope very much to see you next year in 2021 in Ann Arbor, Michigan, either virtually or in person. Take care.
Thank you very much for your warm words.
사회자님 주세요.
I'm thrilled that the next year's conference will be held on and offline in Ann Arbor in the US, and I hope all of you and more participants could gather again there. We have come to the end of Kiom Sar 2020, which was held online from September 11th to 13th. This successful conference was made possible thanks to your enthusiastic participation, and I'd like to extend my sincere gratitude to all the participants and speakers once again. I wish you all the best and good health till we all meet at next year's conference again. Now, I would like to officially conclude the Kiom Sar 2020 International Research Conference. Thank you very much, and have a wonderful weekend.
이때 노래 좀 틀어주시면서 좀 (2020이) 아니라는 게 뭐죠? 2021이 See you at next SAR 2021 이렇게 정리 좀 해주세요. 우리 어제 요청하셨던 거 지금 이렇게 하면 끝나는 거잖아요. 지금 여기서는 이제 인트로 영상 틀고 이제 좀 화면 좀 비치다가 끝낼 거거든요. 근데 여기서 이제 안 끝내고 계속 화면을 열어달라고 하셨잖아요. 그때는 그냥 자유롭게 하시는 거예요?
네네. 그냥 뭐 퇴장할 때 배경음악 뭐 국악 어제 틀었던 거 이런 거
네네.
보시면은 나와서 뭐 원장님이랑 사진 찍으실 분들 이쪽으로 나와주세요.
네네네. 화면 좀 정리해 주세요.
am the moderator of this workshop. My name is Im Jung-tae. Thank you for your participation at this early time of Sunday. This session consists of 2 speakers, and I'm a moderator and a speaker about the safety research of acupotomy. I will delve into what our research team has found out. And the later part of this session will be delivered by practitioner Yoon by demonstrating how do the acupotomy and the precautions that you have to take. And the acupotomy is not familiar with many Americans. So what kind of regulation is it is under in case of in the USA and other Western countries. So I'll start by introducing the shape of acupotomy, followed by the effectiveness. And we have studied the safety of the acupotomy, which started with the setting up the terminology and the safety procedure guideline and precautions about the adverse event, and safe insertion depth of acupotomy by using the fMRI. And the bleeding, bruising, and others, which can be considered easily as the side effect, we have to first set up the definition of the side effect first. So by using the Delphi study, we defined the adverse effects of the acupotomy. And based on the many practitioners of acupotomy, we conducted a pilot study about the feasibility first about the safety research of acupotomy. So I will introduce these kind of researches for you. So when you see this is the needle for acupotomy. It looks like a driver, and you can zoom into the tip part, the blade part, which looks very scary. But when you really try acupotomy, it's not that painful. So it is microimaging surgery is combined with this acupuncture function. So it is widely used for pain management in China, in Korea, and other Asian countries. The theory part will be explained by practitioner Yoon in the second lecture, so you can understand the theory of it later. But looking at it, it looks very scary, and you might think the side effect of this would be more scary than the manual, normal needles. So normally we use acupotomy to treat the nerve root relaxation, but we say, as a joking, that it's rather like a micro-incision rather than nerve root relaxation. So rather than focusing on the effectiveness, we thought safety research should be considered and conducted first, because it goes deep into the structure and it will hurt some of the organizations or organisms or tissues inside. And before the effectiveness research, so we conducted the safety research first. And supported by Kiom, we have conducted a series of studies. So before talking about the safety, let me talk about the effectiveness first. So there have been systemic review-related articles about the effectiveness of the acupotomy, and the practitioner Yoon also did a systemic review-related research. And there have been confirmation research on the effectiveness and the overview of the systemic review of the acupotomy related to the specific diseases such as cervical spondylosis for 2 articles, frozen shoulder for 3 articles, knee osteoarthritis for 1 article, so on. So in total, about 69 RCTs with 7,323 participants. there have been an overview of the systemic review on those research articles. And as an article outcome, in the systemic review, in all diseases that was studied and mentioned above, acupotomy was superior to control group. And you can look into this article by yourself to see the details. And mostly those research have been conducted in China. And when we conduct a systemic reviews on Chinese articles, rather than having a objective standard or evaluation index, they focus on the cure rate or effective rate, just simply saying it is effective, it is useful in curing the disease. That kind of simple category is not objective enough to have a standardized evaluation index. So, and many research published in China have different standards of theirs. So we don't have a consistent and persistent standard that can be applied to different kind of the articles. So some studies, however, used VAS, and which would be very good to have an objective perspective. And in Korea as well, there have been many researches on acupotomy. And in Korea, the Daejeon University is a leading university conducting the acupotomy research, collaborating with the Kiom. And acupotomy, compared to the manual acupuncture, it was a study to see how it is effective on the lumbar disc herniation. So here, we published it here by conducting a research on the 73 people. They have been hospitalized 4 times in 2 weeks. They used acupotomy and manual acupuncture. By having this treatment, how much improvement they had in pain management. And the results shows the acupotomy treatment were found to be more effective than the manual acupuncture. So it is improving the pain intensity and range of the motion of the lumbar region in patients with LDH. And we also have follow-up observation by looking at the VAS. And the baseline was 56.86, and at 4th week, the MCID was 38.19. So MCID, statistically, we can see the VAS, if it is increased by 1 or 2, that is not clinically significant. So to what extent it should be increased to be considered as effective clinically? So this is a standard that we can see. If it is above the MCID, then it is effective clinically. So 50 millimeter was MCID that we have set as a standard. So manual acupuncture, the baseline was 59.25, and it was decreased to 51. So the gap between the baseline and the 4th week, acupotomy was superior to the acupuncture. And about more than 50% have been improved in acupotomy. So compared to the acupuncture, for pain management, the acupuncture was more effective. And this kind of research has continually been conducted. So many people are wondering what acupuncture is. But right now, we are already passing the stage of just introducing it. Rather, it is the stage of widely using it. And actually, our focus was not effectiveness, but on safety. Looking at it at first, the needle of acupotomy, it looks very scary. So we have to secure the safety first in order to talk about effectiveness, because without safety research, it can be harshly attacked by other people or patients. So the first thing that we need to do is how to establish the terminology in common. So the first research is to establish the terminology list. So in Korea, to refer to the acupotomy was used by 77%, and 16.7% is using the terminology of miniscapal needle. So later, the terminology in the world, what word is most used, and worldwide, in English database, Chinese database, Korean database, acupotomy was widely used. So we decided the acupotomy can be a proper word to refer to this treatment. So we published this in an integrative medicine journal. In our initial stage of research, we actually used both of the acupotomy and other words, but later we only use acupotomy to refer to this treatment. So this was the first step to establish the terminology, and we have to set the guideline to have the safety procedure when we do the treatment of acupotomy. The guideline that we are going to introduce here is this article, because we have conducted a preliminary research first based on the domestic research and preliminary research. Then, based on that baseline preliminary research, we did a systemic review also, but I will focus on the preliminary research, basically on what we have to do, the checklist, before the procedure, during the procedure, and after procedure, and also the healthcare-related infection precaution. So these 4 parts are major parts that we have to think and keep in mind in guidelines. So it's more like a checklist. So before the procedure, we have to check the patient first with a vital sign, and also have to think about the position, whether it's a correct position. And in some cases, the site of treatment sometimes is wrong. So we have to check whether we have the proper site of treatment. And actually, cervical vertebrae is really a risky part to do the acupotomy when you go too deep that it can touch the structure itself. So where is the high-risk site and where is mild-risk site? That kind of safe procedures site is also elaborated in the guideline. And during the procedure, if we touch the bloodline there, in some cases during the acupotomy treatment, some people can get fainted. It should be something that we have to keep in mind. When we transect some of the nerve there, it can be a huge problem. So we have to see the limit of the depth of the acupotomy, and also have to check the handle of the needle, and also have to see whether we touch the vessel, and also have to check whether it is too painful for the patient, and also see the vital sign, and also prevent any kind of possible infections. And these are something that we listed in the checklist in the preliminary study. So by having the same terminology and set up the procedure guideline, later we started the systematic review of adverse effects. and also published the result. And mostly it was led by me and practitioner Yoon and practitioner Hwan. And in this research, it was published back in 2018. Up until then, there have been about 45 ocupotomy-related articles, and among them, 15 ocupotomy studies reported adverse effects. So other than that, we don't know whether they had adverse effect and didn't report it, or they didn't have it, but there was 15 ocupotomy study reporting adverse effect, 1 RCT and 1 CCT, and 12 case series and report. So we looked into the characteristics of the studies. We saw the author and the conditions and ICD code and whether they reported the adverse effect and the standard and the precaution to prevent any infection, whether they have level of the severity mentioned in the article. So we checked those kind of characteristics in the article. Actually, ocupotomy can have various ways. So the width of the blade is different, and what kind of stimulation method it will use, that can be very different from one ocupotomy from other ocupotomies. So the depth of the needle and the width of the needle and depth of the insertion, and whether they had a guideline for proper procedure, and total session number, total duration, these kind of information has been provided in this study. And also, the adverse effect can be different depending on the usage of the diagnosis device. So we looked into whether they used the diagnosis devices. So, and how many patients have been participated. And the incidence of the adverse effect also have been checked. Next step was, after having the adverse effect, what was the follow-up measures, whether they treated the adverse effect and there was a causal relations, and the interpretation of the author on the adverse effect. So this kind of case studies developed in the article regarding the adverse effect of the ocupotomy. While summarizing and organizing those results, we also, based on such information, in order to practice safe ocupotomy and in order to follow the guideline, what kind of guideline we need to follow. That was something that we have also considered during this article research, and practitioner Yoon also mentioned about this in detail. And later, we also have conducted the research on the depth of the insertion for safety. This research has been conducted by using MRI. So by using the MRI data of the patient that we want to see, so rather than just define the depth itself numerically, rather, for example, it is used for the transverse process and the facet joint. The depth itself is not clear because we are doing it not using MRI all the time. So we use basically centering on the MRI, the depth itself in detail and precisely. What was interesting, based on the BMI results, actually, the depth itself to touch the structure, and depending on the sex, maybe it can differ from people to people. So having this kind of index and using it, we made a graph and it was submitted, but under review progress. After the systemic review on the adverse effect related research, the next step was we really wanted to do the safety research. But the opinion and the standard of the adverse effect can be different from people to people, especially for practitioners. So we have to have a common consensus first, what adverse effect is. Because bleeding is a common thing that is followed by the acupotomy treatment. If bleeding itself 100% can be considered as the adverse effect, then all acupotomy treatment can be with the adverse effect. So to what extent we can see the normal procedure and normal practice, and to what extent it can be considered as an adverse effect should be considered first. So we used the Delphi study about the definition of the adverse effect in the acupotomy. We asked the opinion by conducting a survey on the experts. What is the adverse effect to be considered in the acupotomy? So separately, do we have to set up definition of the acupotomy? That was something that we did first. And many experts said that pain should be defined first. So pain, if pain is enough to cause discomfort in daily life more than 72 hours, we decided to report it as an adverse effect. And if there's a bleeding that lasts more than 3 minutes after compression, then we will consider it as a hemorrhage as an adverse effect. And also, bruises, if it is more than 3 centimeters in diameter, then it can be considered as an adverse effect. And without definition, all the time if it arises, it can be adverse effect to be reported in case of the hematoma, edema, itching, rash, local infection, and nerve injury. And also systemic adverse effects, worsening symptoms, fatigue, and nausea, vomiting, headache, dizziness, sweating, shock, syncope, dyspnea, whole body pain, insomnia, and infection. If a patient has this kind of symptoms, all the time it should be considered as an adverse effect and reported accordingly. So based on this kind of definition of the adverse effect, we decided to go on to the safety research. And based on this kind of establishment, before having a large-scale RCA, we performed the prospective feasibility safety study first. And the factors that can affect the adverse effect and whether this kind of research really is viable and feasible. So this prospective feasibility safety study actually has been completed and submitted and under review process. And this study is solely led by the practitioner Yoon. And we used about 1,214 acupoints. Actually, the times of the treatment is not important because if it is a single treatment, some people use only few and handful of acupoint. Some other people use hundreds of acupoints. So we have to see the number of the acupoints that we have handled in one treatment. So, and the depth of the needle also have been part of the item for the study. So among 1,185 treatments, about 27 incidents of local adverse effect has arisen. So about 258 treatments, about 8 cases have the incidence of the systemic adverse effect, which is about 3.11%. And later, we call it, as a terminology, MEDRA. So to check the severity and causality, we use a standard of MEDRA. And looking at the level of the severity, about 31 cases were mild and 4 cases were moderate. We didn't have any serious cases as death. And in many cases, the acupoint have just a mild case of adverse effect. And after the treatment, we did a follow-up by using telephone. Before doing the follow-up, we didn't have confidence for patient to answer fruitfully by using telephone, but as many as 98.5% responded faithfully. And in total, one physician have about 63 sessions and 305 acupotomy points a month. That means one practitioner have about 3 to 4 treatments a day. Another interesting point is we looked at the factors that affect the adverse effect. The width of the needle blade and the time of the stimulation and the tingling sensation. If we have this kind of symptoms, it is more likely for patient to have adverse effect. So it is kind of nationwide research on about 70 practitioners in Korea performing acupotomy, and we had the target of collecting 10,000 points. So this study will be finished by September 15th of 2020. We will see the causality, severity, and relevant factors that affect adverse effect. And we will also compare the NRS of pre and post treatment to see the level of pain and pain management. For that, we have developed the standard of operation and also use the electronic data capture system by using a software that is called EDC. We asked a company to develop this kind of software. Actually, based on this kind of software, we had a training session. Before the COVID-19 pandemic, we had a physical gathering to have a training, but due to the COVID-19 pandemic, we have online education. And when they are willing to participate in the training, they first participate the survey itself to see the safety guideline related things and other practitioner related factors that they have to keep in mind. And this result can be used as a variable later to see how many times they can have the adverse effect. So this is the survey form. And practitioners, when they participated, and maybe this can be a hypothetically we said a patient, then we can list up all the history and the records of the patient and the location of the treatment and the depth of the insertion and the way of the stimulation by using acupotomy and how many acupoints they have touched during the treatment and what kind of adverse effect has arisen and what kind of serious response have been reported. and what is the result of the adverse effect and follow-up measures. And while having this kind of materials, we have done the safety research. The Q&A session will be followed after the second presentation.
안녕하세요. 도침치료 시연 맡게 된 윤상훈이라고 합니다. 저는 강남 청년한의원 대표원장으로 있고요. 지금 청년중앙연구소 선임연구원, 그 다음에 대한도침의학회 이사로 활동하고 있습니다. 오늘 여러분과 도침치료 시연에 앞서서 간단하게 치료 이론 같이 한번 알아보고요. 특히 이제 목하고 어깨에서 도침치료 어떻게 하나 직접 치료하는 거 시연 같이 한번 보고, 그 다음에 여러분들이 궁금하다고 했던 우리 한국 밖에 미국이나 이런 곳에서 도침에 대한 규제 같이 한번 알아보겠습니다. 자, 일단 치료 이론 간단하게 먼저 알아볼게요. 치료 이론 아주 간단하게 준비했는데요. 지금 밝혀진 연구에 따르면 첫 번째로 도침 치료는 우리 압통이라고 하죠. 페인, 프레셔, 스트레스 홀드를 좀 개선시키는 역할이 있다고 합니다. 최근에 2017년에 페인 피지션에 시우시아라는 박사가 발표한 연구가 있는데요. 근막 통증 증후군에서 다양한 치매 효과, 침, 전침, 온침, 도침 이런 다양한 치매 효과를 실험했더니 여러 가지의 성과 중에서도 특히 도침이 이 압통을 줄여주는 데 아주 효과가 있더라, 이런 연구가 있었고요. 동물 실험에서는 도침 치료 이후에 염증 수치가 감소하고 통증 역치가 정상 수준으로 돌아왔다, 이런 연구가 2014년에 위지아라는 선생님에 의해서 발표가 되었습니다. 그런 압통과 말고도요, 우리 또 도침은 끝 모양이 칼 같은 거잖아요. 그래서 미세한 절개를 통해서 우리 신경 압박, 널브 엔트레먼트를 릴리브 시켜주는 효과가 있습니다. 이거는 따로 근거를 말씀 안 드려도 수근관 증후군이나 이런 거에 대한 연구가 많이 진행됐기 때문에 여러분이 알 수 있다고 생각하고요. 그 다음에 근육을 이완시켜주는 효과가 있죠. 릴리브 머슬 톤. 특히 우리가 흔히 오는 외래에서는 이 릴리브 머슬 톤 효과를 가장 많이 씁니다. 도침 치료를 통해서 근육을 이완시켜주면서 어떤 흉곽 출구 증후군이나 근육의 각종 긴장을 저희가 풀어줄 수 있고요. 여기에 대한 연구도 있었죠. 근긴장 완화에 대한 연구는 2017년에 아큐펑처 리서치라는 데에 근육 도침 치료를 했더니 어떤 MRI 익스프레션이 돼갖고 근육의 이완 효과가 좀 있더라, 이런 연구가 있었고요. 그 다음에도 제일 사실 재밌는 도침 치료 효과는 어떤 유착되어 있는 관절낭을 절개시켜주는 효과, 디섹션 조인트 캡슐 어텐션을 해서 우리가 진짜 50견이나 이렇게 딱 그런 질환들을 개선시키는 효과가 있죠. 이건 이제 50견에 대한 치료 효과도 2019년에 지안위라는 선생님이 발표했고요. 저도 이 손가락 관절염에서 도침 치료 효과를 케이스 논문을 발표한 적이 있습니다. 이렇게 간단하게 4가지 압통 개선, 그 다음에 신경 포착 해소, 그 다음에 근육 이완, 그 다음에 유착된 관절낭에 이걸 절개해준다, 이런 4가지 효과 기억하시면 될 것 같고요. 자, 여러분 이제 치료 이론 다 알아봤으니까 좀
Dissect joint capsule adhesion. As we briefly went through the theory, let's now talk about something more practical. So based on the theory, let's move to something practical once again. And when I do the acupuncture treatment, I think the stimulus quantity is the most important thing. And there can be many methods for modulating the stimulus quantity, the size of needle and what kind of needle you're going to use, and how deep the needle will be inserted, and lifting and thrusting, and the appropriate amount of stimulus quantity has tremendous impact on the effectiveness of ocupotomy. If there's too little stimulus quantity, it's not going to be effective enough. For example, many elderly patients come in and you give normal acupuncture treatment, and the next day they come back and say, oh, nothing has changed. So it means that stimulus quantity is not strong enough and it's not effective enough for those kind of patients. But we shouldn't have excessive stimulus quantity. So if you look at the excessive stimulus quantity, of course, it says adverse effects. So if you just give too many acupotomy needle treatment, then the next day they feel even more painful. So the appropriate therapeutic effect can be brought about by based on the appropriate stimulus quantity, and this is not easy, and it should be based on the clinical experiences. You will be able to get those answers based on your experiences. So there are many types and techniques in acupotomy, and some people like to do it very strongly, and I kind of believe that less is better. First, you can start with something less and then gradually increase. So maybe you can try with the regular acupuncture, and if it doesn't work, then you move on to the acupotomy, and you start with 2 points and then move up to 3 points or 4 points. And if you start with 5 points or 10 points of acupotomy treatment, from the beginning, the patient may not come in because they may feel pain. So maybe starting with acupuncture to acupotomy and using less points to more points would be better. For example, if you have to kind of make micro incision for nerve, for that case, you have to use acupotomy because it uses the blade needle. But if you're using acupotomy for just regular pain, maybe you want to target those patients who do not experience a lot of effects from the regular acupuncture. And for those patients who have nerve entrapment, then we would have to use acupotomy to make incision of the nerve. So before I start with the demonstration, let's check the safety precautions. Well, based on my experience, there's not a lot of adverse effect, but you have to abide by this safety precautions. So the first one is entry point marking before treatment. Because if you don't mark it, even if you find it, you may kind of insert it in different areas. So use the pen or your fingernail to mark it. And the second one is really important. Maintenance of the blade in a parallel orientation to nerves and blood vessels. So it means the blade needs to go in parallel to the nerve or blood vessel. But if you put the blade in perpendicular to the nerve, you may cut it, so it can be dangerous that way. So it shouldn't be perpendicular. It should be parallel to the nerves or blood vessel. Third one is also important. Slow insertion to minimize damage. Well, let's say you insert the blade perpendicular to the nerve, but it's not going to be cut if you insert it slowly. But still, if you hurry up and then insert it too fast, then it will cut the nerve and or blood vessel.
잘리는 걸 예방할 수 있습니다. 일단 보여드릴게요. 자, 그다음에 4번도 아주 중요한데.
The fourth one is also very important. Check for pain and numbness during procedure. So when the patient says that they're feeling shooting pain, then you're touching the nerve, and if it hurts, then you're touching the blood vessel. If the patient has that kind of reaction, you have to pull it out immediately. And next one, you don't want to insert too deep for quadratus lumborum, so do not insert too deeply. And I think, well, I'll demonstrate that later. So let's say this is skin, and the most difficult thing is just penetrating the skin. If you press too slowly, it's not going to penetrate because there's a blade needle. So it just hurts if you just press just a little bit. So you need the snap to go to allow the blade to penetrate the skin. But if you do that, it can be dangerous. You first have to make contact with the skin. Well, of course, you have to mark it first. You contact and then use the snap to penetrate the skin. And it's going to be less painful if you use the snap. And that is very important to minimize pain when your needle penetrates the skin. And from there, you have to slowly insert the needle. So even if the tip of the needle touches the blood vessel, it's not going to cut it. And if the patient says they're feeling some pain, then you have to pull it out like that. And you see the blade. Well, I use Galaxy phone, and it doesn't seem to be very good in terms of focusing. So the blade direction should be like that. And let's say this is nerve. Let's say this is nerve or blood vessel. Then you want to have the needle parallel to this nerve. If you insert it perpendicular to it, it may cut it. So it shouldn't be perpendicular, it should be parallel to the nerve, and that would be the key for safety. And as I said earlier, it should be inserted slowly, and the patient may bleed after the treatment, so you have to put pressure to stop bleeding. And in case of neck or bottom, there's a possibility of hematoma. So the finger, you have to use your finger to press it until the bleeding stops. So let's get started with demonstration. So today I'd like to focus on neck and shoulder. And here the joint capsule and nerve can be a little bit risky, so we'll focus on the muscles today. There are many types of ocupotomy, and I prefer less stimulus. So when you first try ocupotomy, I think I highly recommend that you start with less stimulus. So the first muscle that I'd like to talk about is trapezius. So if you look at the picture, those are TP. But you don't really have to memorize this TP. I'm just putting it there for reference. So you can just find the pressure pain point and then insert the needle. And it's important that you hold on to the muscle and then insert. I'll show you how. So let us get started with the demonstration of ocupotomy. And first, let's get started with the upper trapezius. And usually pain pressure points are these areas. And then maybe you can ask the patient to pinpoint where is the most painful. You can ask the patient, these are 1, 2, 3, which are the most painful point? He said 1 and 2. So the important factor in treating upper trapezius is the direction. Use the alcohol swab thoroughly. And if you put the needle that way, it's not good. So just grab the muscle like that and then insert it in that direction. I don't do a lot of lifting and thrusting, 1 or 2 times, and then I'll just pull it out so that patients do not feel painful. And after that, you put Band-Aid. It's very easy. You just have to find the direction and then insert the needle. Next muscle is Levator Scapulae. That starts from the transverse process of cervical vertebrae to superior angle of scapula. Now, in terms of for the superior angle of scapula, there's a possibility of pneumothorax. So when you're inserting near the neck area, be aware of the needle inserting too deeply. Yes, this time Levator Scapulae is the target muscle. So it starts from the lateral side of the cervical vertebrae, and then the muscle goes in that line. And when you're doing the ocupotomy, sometimes the patient will feel the pain at that area, but ocupotomy in this area is very tricky because it's near the lung. If you have to do it, then you have to find the pressure point exactly. It's risky, so many people use the cupping therapy for this. And the lateral side of cervical vertebrae is the most targeted area. So there's hairline, interior hairline, and the Splenius Capitus goes like that, and that is where the Levator Scapulae is. And you have to find the pressure pain point, as I said earlier. You don't have to remember the points that are indicated on the textbook or anything. You just have to find the pressure pain point. So which area is the most painful area? So 1, 2, 3, which is the most painful? He said 1 is most painful. So let's target that point and use the alcohol swab to clean it. And this is new needle once again, and you can just insert it. But when you're dealing with needle, when you're dealing with neck, of course the direction and speed will be very important. So, but if you get more experienced, you can go deeper. But if you're a beginner, make sure that it goes less than 2 centimeter, because if you go too deep, then there may be some nerve damage. So yeah, make sure that you put in within 2 centimeter, and especially for women, you have to be more cautious. So that's my recommendation. And these 2 points are good for those with neck pain. And the third muscle to target is semispinalis capitis, semispinalis cervicis. And this area is good for treating headache. And you can target the lateral side of the cervical spinous process. If you get too close to the center or outward, then you can stimulate spinal cord or nerve root. So you see the yellow point there. You should target that area and then insert maybe 2 centimeters or less than that. Next one is semispinalis capitis and semispinalis cervicis. So it's that area. So it's next to the cervical spinous process. And some people say that they're feeling pain over here. Find the pressure pain point. And it's exactly same as the levator scapulae. You should not insert too deeply, or if you get close to the center, it can damage the spinal cord, or if you go outward, then a nerve root can be damaged. And that maybe 2 centimeters from the cervical spinous process would be important. I'll make the PPT presentation file so you can refer to it when you're treating the patient. And this is also same. You have to find the pressure pain point. Is that hurt? He said yes. Yes, like this. You don't have to go too deep. For men, 4 to 5 centimeter insertion, you can reach to the articulus minus, but you're not targeting articulus minus, but just the muscle, then you don't have to go too deep. So for men, you can aim to go in for 2 to 3 centimeters. For women, 1 to 2 centimeters. Of course, maximizing the efficacy is important, but safety is more important. Next muscle to target is Scaliness Medius. So the other muscles are easier to insert, but many people, many doctors are scared to use these points. So, and this muscle is often frequently used, and the posture for posture for treatment is very important. He has to lie down and turn the head like that, and you have to insert less than 1 centimeter to be safe. So let's check out the demonstration video. Can you turn face upward? And this is really important compared to the previous points because this is really frequently used. So turn the head like that as much as possible, and can you lift your head a little bit? And you can see the SCM right here. You can relax now, and at the back of the SCM, there's Scaliness Medius. and there's a blood vessel there too, and that is the pressure pain point often the times. It depends on patients. Yes, as I said earlier, this is frequently used point, but some people, some doctors are scared to treat the area. It is risky for sure, but if you abide by the safety precautions, it's gonna be fine. So starting from the ear, and that is the SCM, and there are many arteriovenous, so you have to be very cautious. You have to find the Scaliness Medius first and insert within 1 centimeters. And direction is the same, and consider the blood vessel direction, and then insert it like that, and then pull it out. That is, the efficacy is sufficient. You don't have to go too deep. Next is Scaliness anterior. This is a little more difficult. It's kind of difficult to find it. So that's why many doctors use Scaliness Medius. First, they try the Scaliness Medius, and if things doesn't work out for numbness or thoracic outlet syndrome, then we move on to Scaliness anterior. So turn the head like that, and then you have to find the Scaliness anterior and use your finger and isolate your muscle with using your fingers, and I'll show you with video. It's a little bit more difficult with the Scaliness anterior. Yes, turn the head as much as possible, and behind the SCM and that muscle is the target. If you go too deep, then the pneumothorax can be caused. So use your finger to fix the Scaliness anterior. Use the alcohol swab to clean it. And you have to really isolate this muscle with the finger, and you can see the bulging there. And then insert it really lightly, just maybe 0.5 centimeters. You don't have to go deeper than that. So less than 0.5 centimeters will be ideal. And I'll put the Band-Aid on it. Was it painful? Not at all. So we've looked at Scaliness anterior and Scaliness medius. So once again, there's SCM here, and behind there's Scaliness medius, and then below there's Scaliness anterior. These are really, really important points and very effective for treatment. And can you lie down, face downward? Next is Splenius Quepetus. It's good for headache. And of course, you have to find the pressure pain point. And its face, the muscle is on the outer layer of skin, so you can insert about 1 centimeters or less than that. I'll share you the demonstration video. Please face downward. And next one is Splenius Capitus. It's good for headache. So it seems like I'm giving you too much needles. And it starts from there to it, and it follows up along to the mastoid process. And if there's tension in that area, it can cause headache. Of course, you'll have to press it to find the pain point. However, mostly there's this along the anterior hairline you can find the pain point. So just press it to find the pain point. Most of the people feel the pain in this area. Neck is very important area, but especially C1, C2 level, you should never insert it too deep. The muscle is on the outer layer of skin, so less than 1 centimeter. You should insert it just lightly and pull it out. If you want to stimulate more, you can do the lifting and thrusting maybe 1 or 2 times, and that's enough. If the patient wants it and if they can take in a lot of stimulus, then it's gonna be okay, but you don't have to do it. So we really have to focus on minimizing risks. So we checked with the neck, and finally we can move on to shoulder. So the first area we have to see is supraspinatus. So you have to find the spine of scapula first. On the picture, it inserts directly to the fossa supraspinata and scapula, but inserting it toward the spine of scapula can be safer. So for example, if the patient has subacromial bursitis, kind of impingement syndrome, this point can be very helpful. So in that case, you'll have to really treat this supraspinatus. Let's check the shoulder area, shoulder muscles. And let's look at supraspinatus. So there are 2 major areas. The first one is over here. And you'll have to first find the spine of scapula, and the upper part right here will be supraspinatus, and the lower part is infraspinatus. So the patient here today is very fit, so it's kind of easy to find the spine of scapula, but overweight patient, it may be difficult to find the point. So this point again, direction is important. So pain point can be 1, 2, 3, and then you have to find pain points along that line. If you insert it like that directly toward the fossa supraspinata, and this fossa supraspinata is curved, so there's a possibility of reaching to the lung. And overweight patient, maybe you have to insert it like 5 or 6 centimeter, and you get scared. You may get scared because it may reach to the lung. So my recommendation is to insert it toward the spine of scapula. So even if it goes deep, it will not affect the dangerous area or lung. So inserting in that direction is my recommendation. So inserting downward like this. Of course, the blade should be inserted considering the alignment of muscle, and insert it like that, and it reaches the bone immediately, so you can safely make treatment. Next is infraspinatus muscle, and it's kind of easy to find, and as well as the pressure pain point. But if the patient is overweight, it may be difficult to find the fossa supraspinata. And when you raise your arms like that, it may be more difficult to find the infraspinatus muscle. So first you have to find the muscle first, and there are many pressure pain points, maybe 3 or 4 points, but you don't have to insert to all of them. You can find 1 or 2, find the most painful point. You can go as deep as 3 centimeters until you reach to the bone, but that is not necessary. You don't have to insert it too deep. And that is spine of scapula. And the pain point is not set or designated, so you can just find the pain point. And people often feel pain around that area. So which part is the most painful area? He said, everywhere. Then you can choose the point that you want to insert. Something like this. The needle reached to the bone, and it seems like 3-centimeter insertion. An overweight patient may have their it's possible to go in as far as 5 centimeters, so don't be too ambitious. And a patient may bleed after penetrating the skin. And it's important that you press it until the bleeding stops, because there's a possibility of hematoma. So press it until the bleeding stops. There's not a lot of bleeding, just press it a little bit and then the bleeding will stop. You can check, but it seems like the bleeding stopped. So face upward again. Let's move on to the insertion area. We'll do the insertion area for the supraspinatus. This is used, but not too often. If the patient has some issue with tendon, then we will target that area. It's easy. Well, actually, it is in that area. It's not at the lateral side. It's that area. So first, find the bicep tendon. Well, I can feel this bicep tendon right now. And right next to it, there's the insertion area. So find the pain point around here. He said, I'm okay. You don't really have to insert at that pain point if the patient doesn't feel pain at all. Next, we'll move on to deltoid. There aren't often the case where the patient feels pain in this area alone. So there aren't many people who feel pain right here at the deltoid. There are many people who feel pain at the upper area, but not at the deltoid area. But if they feel pain in the lower area, then you have to target the deltoid. And you see the yellow spots on the arm. It doesn't have to be there. So just find the pain point and then treat the patient. And there's no dangerous structure for deltoid, so the insertion is easier. There are some people who feel the pain at this deltoid area. So if you feel pain in this area, then you have to treat that area. But some people feel pain in deltoid, maybe around here. And that is exactly the deltoid area. And that is the insertion area. And some people feel pain in that area in the middle. Just find the pain point, and then it can be anywhere around here. So you can just find the pain point and insert it. You can just insert it. There's not much precaution for deltoid area, and depth, it doesn't matter as well. So that is the insertion area, and our patient today is healthy, so I am not going to target the area. So I'll target the middle area right over here. Something like this. And maybe you can do lifting and thrusting. You see a little bit of bleeding. You can use the alcohol swab to stop the bleeding, but it kind of prevents it doesn't really help with the stopping the bleeding. So just use the Band-Aid and then press it until the bleeding stops completely. So we focused on muscle ocupotomy only, and that's it for the demonstration. And lastly, I will talk a little bit about regulations on ocupotomy. In case of Korea, ocupotomy treatment is currently included in the national health insurance category, so there's no issue with regulation in Korea. And we have some audiences watching this training session from workshop session from all over the world. So there are many states in the U.S., but I don't know all the states because laws are different from state to state. But I've been to California, so I'll just give you an example in terms of California today. So this is the regulation indicated in the acupuncture board, and I highlighted with blue here. And in case of Korea, we have no limitation on types of needle, but in terms of California, they specify that they have to use acupuncture needle, not a different type of needle. So are we using needle or acupuncture needle for ocupotomy? So this is research on terminologies related to ocupotomy. There are many terminologies, needle knife or needle scalpel. And all these terminologies were combined together, and the official term is ocupotomy by MESH term. So that's the entry term. So ocupotomy is acupuncture needle based on its theory and practice. So the ocupotomy needles are imported to US and they are used. Thank you very much.
안녕하세요. 방금 발표한 윤상훈이라고 합니다.
is Yoon Sang-un. I just made my presentation. And Practitioner Yoon, can you hear my voice? And this stage is very good. And it looks like I'm kind of judged in a big position. And how you're spending your Sunday? So I'll move on to the Q&A session. So for Q&A, there are 2 questions for Dr. Lim. I will ask you from the first question. And I think other people can see the question. Do I have to explain it? So maybe Dr. Lim, can you also do the translation and answer? Don't be nervous. You can do both. So, can I answer the question now? So, the first question is also, as acupuncture is used for removal of the unnecessary adhesion of joints, targeting exact point seems highly important for therapeutic effect and safety. It is recommended to use real-time sonography or C-arm. And do you use these in your hospital, or blinded intervention is safe and effective enough? That was a question. So I think this is a question that I can answer based on my experience and from my perspective as a domestic KMD. So I think the person who asked this question is the person who has the expertise on the acupuncture, and he already acknowledged the importance of the targeting, the importance of the exact point positioning. So that is really important. I know that, and everybody knows it. But we have limitations about the cost and others. So some people use sonography to do the acupuncture, but in Korea, we're not allowed to use a C-arm. So we actually don't have any people using C-arm, from my understanding. So without sonography and C-arm, is it enough? Safe enough or effective enough? I think the muscle that I show in my demonstration and that light within the boundary of the safety guideline, blinded treatment itself can be safe enough. But if we can talk about the adhesion of the joint, cervical cataract, they can be safe. But others in Chinese research, manual manipulation is safer. But we have to also think about the coverage of the national insurance. When we do the acupoint with the manual manipulation, I think that is not effective economically for the practitioners. So I have been doing this acupoint for several years. So as long as you follow the safety guideline and find the exact point and find the exact direction of the needle, that it is safe enough and effective enough. So I know that sonography and C-arm, it is safer, but you also have to think about the reality and limitations. So you have to follow the guidelines, safety guideline first, and please avoid what is risky. I think that is what I can say. Do you think it is enough as an answer? So I can add my comment on it. Actually, I'm conducting the safety research. So adverse effect, that is not that severe, but it is not because the acupuncture is safe, but because the doctors in Korea, we have limitations of using sonography. So we are more like a defensive in doing the treatment. Rather, the safety research in China, they have more cases of the very severe and deadly side effects. They are more aggressive in using the ocupotomy treatment. But in Korea, we are very conservative and defensive in treatment. That's why that is a difference, and we have to keep on conducting research and have to be equipped with more knowledge. And if we can use sonography in treatment, maybe it'll be better in effectiveness. That's my comment on it. That is the exact point that we can go forward. I also traveled to China to see the demonstration of the ocupotomy. They're very rough. It's more like a surgery. They also have anesthesia or others. Maybe they're aggressive. And yes, they have more cases of these severe adverse effects. I also will go to next question. The next question is about the depth of the needle using the MRI. So if you look at the graph of the result of the MRI study shown in the PPT, the error range of the depth measurement value of the dangerous surgery structure seems very wide. Looking at this part, if you adjust the depth of the acupuncture procedure by simply referring to the BMI, there's a risk of the medical accident. Do you have any research plan on the safety of ocupotomy using the image guide in the future? That was a question. Yes, true. And we are doing the review process, and this is something that people also point out. And in the revision process of this article, we will not use a definite terminology of the depth of the safety. Rather, we will focus on we do not have many articles. We have limited number of patients, 158. The data from them, although it is limited, it is something that we can use as a reference. That much would be enough as a reference. Rather than providing the mean value or safety depth, we will focus on and we will elaborate that it is the result of the 158 patients only. That is a direction that we are going to do in the revision process. And what is more important here, as the person who questioned this mentioned, this is really important to have the exact acupoint related guide and research. So those people are using and doing the research on the exact acupoint and positions to use as a guideline. Actually, we also have this kind of discussion with practitioner Yoon, but in the future research, as we have done in the safety research with the Kiom, we can have a further research with the consultation of the Kiom. We can go forward in the advanced research, the safety depth of the insertion of the acupoint, which would be very useful because acupuncture and ocupotomy, the position and the point that we use are very different. So the same amount of effort should be done in ocupotomy on the acupoint. And if it has, we have to have the clinical usefulness, because the advancement of the medical and clinical part and devices, we can have more selection and options of the minimal size of the sonography-related devices. If we can have the portable size sonography, that would be very beneficial. Maybe we can talk about this with the Kiom. That would be better in the future plan. Thank you for your answer. I think portable is something that we can work on later. And there's another live question for me.
신경이나 혈관을 절단하였을 경우 응급 대처나 향후 치료는 어떤 방향으로 진행하는지 궁금합니다. 이런 어떻게 보면 좀 극단적이죠. 절단을 했을 때 어떡하냐 이런 질문이 들어왔는데 절단은 사실 거의 없어요. 절단은 거의 없고 신경염 정도가 많겠죠. 맞고 나서 계속 저려요. 찌릿찌릿해요. 뭐 그런 거가 있겠고.
There's a possibility of inflammation.
일단 혈관 먼저 말씀드리면은.
So let's focus on blood vessel first.
뭐 우리가 미세 혈관 조그만한 거 그런 거
And micro blood vessel is easy to prevent, easy to stop the bleeding. But if you cut the nerve, then we will have to think. The nerve at the peripheral area is easy to be regenerated, but there's a possibility of incision at the neck and important nerve at that area. And the patient needs to know. So we have to ask the patient, can you move your hand or arm? And if he cannot or she cannot move, then what we have to do is go to the hospital in Yangjae-dong district. There's not something that we can do, and there aren't many doctors who can do that surgery, the nerve adhesion surgery. We should never cut the nerve, and it's not easy to cut it. If you insert it really fast, and if you have the intention of cutting the nerve, then you can cut it. But it's really difficult to cut the nerve if you abide by the safety caution. If that happens, then call the hospital at Yangjae-dong. And if the patient feels numbness, just a little bit of the numbness, it's fine, but cutting the important nerve, then the surgery would be necessary. I hope I answered your question. We don't have more questions on the website. Would it be possible? Can I wrap up now? So thank you so much for listening, and I hope that you learned something about acupotomy. We have limited time, so I wasn't able to give you too much information. And would you like to give some comment lastly?
So we have done many researches with Kiom, and also this time in SAR, we have a privilege to do the presentation about our research. And it was really good opportunity for us to introduce acupotomy. Thank you for giving me this opportunity. And later, if we have chance, I would like to have another case of instruction on the acupotomy. Thank you very much. 하고 있잖아. 그러면 지금 나가고 있다는 표시. 아이고, 네.
눌러보고 이런 식으로 돼. 될 때만. 난 너무 헷갈리는 거.
Good morning, everyone. My name is Byung-Chul Shim from Busan National University, South Korea. I'm feeling very honored and privileged to chair the plenary session 5, which is the last session of the Kiom Sar 2020 International Conference. The title of this session is Policy Making and the Implementation of Traditional and Integrative Medicine to Solve the New Socio-Medical Problems. The live Q&A will continue after the last presentation. If you scroll down the online conference hall website, you can select the speaker and write the questions. Now, let's start the first presentation. Let me introduce our first speaker, Professor Dong-il Kim. Dong-il Kim is Dean of the Korean Medical College of Dongguk University and the Chairman of the Society of Korean Medicine, Gynecology and Obstetrics. Professor Kim is the head of CPG research for menopausal disorders in Korea and has been responsible for several infertility studies. He will give a presentation on prescription network analysis of support project of Korean medical treatment for infertile women. Please welcome Professor Kim.
예, 반갑습니다. 오늘 한의 난임 치료 지원
Good morning. I'm very privileged to make a presentation on the study on herbal prescriptions on Korean medicine support project for infertile couples using network analysis. My content consists of background, introduction, method, result, and discussion. First, background. We have increasing number of infertile couple. It reached about 100,000, and less marriage rate reduced it to about 150,000. But for males, it reached about 60,000 every year. And this result is based on the National Health Insurance infertility diagnosis results. However, Korea have a huge difficulty of low birth rate. And infertility issue is really big issue as well. So many people prefer Korean medicine support. So IVT is not covered by the national insurance, and Korean medicine-related infertility treatment is not covered by the national insurance. So local government, together with our society, we partially support some of the treatment cost. Gyeonggi-do is one of the largest municipality of Korea. It also participated on the project for the infertility. For 3 months, it supports those infertile couples in Korean medicine treatment. And then for 6 months after that 3 months of the treatment, they can have observation period. And after that period, they can also be supported again. Back in 2017, about 231 participants finished the treatment and 26 participants became pregnant. In 2018, 227 participants finished the treatment and 25 became pregnant. And it is lower than the fertility rate. It's not about the Korean medicine related issue, but because those enrolled in the infertile treatment, they are really those who failed to conceive for a long time. That was the reason behind this low birth rate. And the prescription of Korean medicine, we think about more on the gender and their age, constitution, thereby providing catered treatment for them. But the issue is the catered treatment have difficulties in treatment standardization. For national support, the standardization treatment is important. Therefore, before starting these support for treatment of infertile couples, we thought it is necessary to establish a guideline and standardize the treatment. So we established this common consensus among experts. So for those related to the age increase, we recommended Yongninju as a regular prescription, and those chi stagnation, 조경종옥탕 is provided. Those obesity or PCDOS related patients, we recommended 창보도담탕. And those circulation or blood stasis related issue, we provided 계지 복용환. And those chronic disease related patients with chi blood deficiency, we provided 옥토육립탕 and 규비탕. These are provided for the follicular phase. And luteal phase, we provided the 베란착상방, 안전이천당, and 태산반석상. And this is for reference and guideline. This is not strictly followed, so that the experts and the clinicians can use it as a reference while catering their treatment to the condition of the patients. And standardization is highly recommended. What you see right now is the BCB, and this is the standardized prescription that I use and I promoted. And this is widely used during the luteal stage together with the 안전이천당 and 태산반석산 for 20 days after the during the luteal phase. We have many experiments about BCB. This have the anti-oxidative stress protect ovarian follicle cells and also increase the newborn pop. And BCB is also increasing the implantation efficiency on mifepristone-induced implantation failure model, which refrain those women from having miscarriage. And also about the receptivity, the investigation about the expression of the matrix metalloproteinases expression were very important. So we supported this kind of process with BCB, and also we show it has high effectiveness. And we also have looked into the previous studies on Korean medicine infertility support project. There were in large 3 different kind of articles. First is about the result analysis. Second, study on pattern identification of patients. Third, the study on factors influencing pregnancy. And these are written by me. Even so, we have faced a lack of research on the relation of the prescription because between the stages, different prescriptions should be provided, and based on the prescription, what kind of influences it can have, that relation-related research were highly being absent. So we have to check the characteristics of the prescription by having this kind of research, thereby establishing better in terms of the standardization prescription. That's why we felt the need to study the relation of prescription. Let me go to the instruction. This is a brief introduction about the network analysis. This is widely used in different domains of the research. And we can see the link between the nodes and and nodes. So looking at this pictogram, we can see the interaction between the nodes, and we can also see the importance of specific individual node. In network analysis, we have to focus on node and link. Node is individual node, the circle, and link is the linkage between the two. And the bigger the node is, the more influential it is. And the link, if it is thicker, that means it has high relation. And the strength of a network can refer to the thickness of the link. And here you can see agent vector centrality. Agent vector centrality is the measure of the influence of the node in a network. And high agent vector score means that a node is connected to many nodes who themselves have high scores. And there's also degree centrality analysis. Degree means the degree of the node in a network means the number of connections it has to another node. So the more link it has, the higher degree it has. And to be specific, we have in degree and out degree in the degree centrality. And it can be analyzed by the number of tails. If it has high in degree, that means they have high interconnection. And the number of tail ends adjacent to a node is its out degree. So we can count the number of the head ends adjacent to a node so that we can see more closely the connection between the two. Cluster analysis is visually, we can see how those nodes are clustering, in what shape it is clustering. Thereby, we can see the importance of that connection and interaction. Let me go to the methodology part. We collected data first, and we did a pre-processing of data and conducted network analysis. From 2017 to 2018, Gyeonggi-do Province, among those who participated in the Korean Medicine Infertility Support Project, all data after being anonymized, we analyzed the prescriptions for 453 participants who finished the treatments. Their prescription record has been left there. So after analysis, we can find that about 66 types of herbal medicine were prescribed totally. And 49 out of 453 participants became pregnant. The result of the project in brief explanation, on average, their age were around 37 for female, their spouse 39. They have about 64 months of marriage period, and they have tried about, on average, 52 months to conceive. That means they have long period of marriage and have been failing in conception for a long time. And this is the data pre-processing. And if the names of the prescription are a little different from one another, we just combine them together into one prescription. So with a little bit of addition of the formula there, we just have it as a basic prescription, and it is far different. It is other prescription that we categorize. And next stage is result. And this is the visualization of the network analysis. In the upper part, you can see a little dots there. That is other prescription which failed in conception. And what is near, they are successful conception results. And mostly 안전 1차탕, BCB, 용린주, 태산반 석상, 창보조감탕, those have thicker lines, and they are composed of the standardized prescription and focused by us. And those failing in conception, they are similar prescription to this. But for your reference, those other prescription other than the standardized ones, they have very little likelihood in conception. This is a net visualization of the network analysis. So what is in purple color, that are BCB and JJT. They have big nodes showing high relevancy, and 용린주 in blue, 안전 이천탕 in sky blue, and 귀비탕 sky blue, 창부도 탐탕 green, and 계지봉령만 in light green. They also have relevancy. And for those who continued 12 weeks of conception and those who failed to maintain the conception, we divide them into two different groups and analyze the condition. And we saw 조경종옥탕 is really related to their successful maintenance of the conception. And 배란 착상방 and 창고도담탕 is also useful in maintaining the conception and pregnancy. Those who failed conception, it is also beneficial because it is helpful for preventing the miscarriage. So all in all, BCB and JJT and 안전 이천탕, 용린주, those combinations are widely used in visual network analysis result. And here you can see similar results. So JJT, BCB, and CDT are really important part in the node in this visualization. This is a result of the degree centrality analysis. We saw the centrality. See here you can see BCB and JJT are most important in prescription and widely used. And this is closeness centrality. Closeness centrality is showing what is most influential in prescription network. Here we can see the BCB and JJT, and their combination shows the high closeness centrality, and these combination is closest to the standardized prescription. Although 안전 이천탕 and 용린주, and they are useful and widely used, but the importance and the influence of the 배란착상방 and 조경종호탕 is higher and more closed. And this is a result of the agent vector centrality. Here, likewise, BCB and JJT are the most important ones. If we use BCB, it has high relevance with other prescriptions. So in our project, BCB is one of the most widely used independent prescription that we use. And this is a result of the cluster analysis. Collecting all the nodes and link and making the cluster, we see what kind of shape of the cluster we can see. So here we have 5 different clusters. They are far different from one another. 양격산호탕, it is a Seoul prescription that is not related to others. And the upper 2 group and bottom 2 group, the bottom 2 one, they are 용린주, 안전 이천탕, and other prescription that is widely used in main prescription are being shown here in the bottom 2. BCB and JJT and YLZ and SJT, they can be standardized, and possibility of the standardization is high in those prescriptions.
결과를 조금 요약해 드리겠습니다.
Let me summarize the results.
66종의
A total of 66 different medications were used,
실제로 임신한
of which
사람들에게는 23종의
23 were used for pregnant subjects.
그 상관성에 대한 분석들 어떤 처방들이
But we can confirm that relatively high frequency prescriptions such as 배란, 착상방, 조경, 종옥탕, 안전 이천탕, 귀비탕, 육린주, they are mostly used for pregnancy. What is frequently used is BCB and JJT. They are thicker in line and they have more influence on others. So BCB and JJT, they are the most standardized prescription that we can see. So when we see the connectivity and the centrality of the network, 배란 책상방 and 조경 종옥탕, 안전 이천탕 and 육린주, their in-degree centrality was high, especially the in-degree centrality of 배란 책상방 was significantly higher. When we do the analysis on the nodes and the link, in the closeness analysis, 배란 착상방, 안전 이천탕, 육린주, and 조경 조곡탕, they are center of the centrality. And the analysis of eigenvector centrality, we can see that 배란 책상방 and 조경 조곡탕 are not only influential to each other, but also influential around them, especially the two prescriptions are affecting each other. Discussion. The meaning of this kind of analysis is those who were successful in conception, they use a specific prescription. And it shows that when used a standardized prescription, it is more likely for them to be pregnant. And those who maintain the pregnancy over 12 weeks, they use 배란 착상방 more. And regardless of their relevance of the 배란 착상방, we can see the 배란 착상방's importance itself here. And the combination of the 배란 착상방 and 조경 조공탕 can be seen here in the result. However, we also have the limitation because it was a pilot study, and with one prescription, can we define that prescription alone? In some cases, one person can use up to 5 different prescriptions. And that many prescriptions, each of the prescription, should we see it individually or combined together? That kind of limitation is existing here. And it although has meanings because regardless of the number of prescriptions they have, it shows a common result. What I want to say lastly is that in Korean medicine, the catered prescription and treatment is really important, but to apply it in public and socially, standardization is also a very important factor. So we recommended a standardized prescription. In the clinical trial and the real study, 조경 조곡탕 and BCV, they are mostly used and most successful the most. And also, it shows a possibility of the higher successful result of the combination. We will keep on doing the further research so that we, Korean medicine, can fulfill its responsibility of the society. Thank you very much.
Thank you for your speech about the project of Korean medical treatments for infertile women in Korea. Thank you. Now, I'm pleased to introduce Professor Jun Mao. As you know, Jun Mao is a very famous professor. Dr. Mao is the chief of the Integrated Medicine Service and the Lawrence S. Rockefeller Chair in Integrated Medicine and Memorial Sloan Kettering Cancer Center. and the professor of medicine at the Yale Cornell Medical College. He is the immediate past president of the Society of Integrative Oncology and the co-president of the Society for Acupuncture Research. Dr. Mayo, are you ready?
Yes, I'm ready. Can you hear me?
Okay, very nice. Well, and please give your lecture. Yeah.
Good morning if you're in South Korea, but here in the United States it's in the evening. So have a good day wherever you are. So I'm very honored to be asked by the Kiom organizers to give this talk on evidence-based growth of oncology acupuncture. I'm trying to advance the slide. Oh, yeah. So in the United States, about 6 out of 10 cancer patients use a type of complementary and alternative medicine, such as acupuncture, or herbs, or massage, and 4 out of 10 use on any given year. So this high rate of use of complementary and alternative medicine really asks for how we best to bring this type of therapy together with conventional oncological treatments such as surgery, chemotherapy, or radiation. So basically, sorry. Okay, good. So sorry for the technology. So at the Memorial Sloan Kettering Cancer Center, we are the oldest private cancer hospital in the world. And 20 years ago, we recognized the needs to bring together CAM together with conventional cancer treatment and establish the first integrated medicine center in North America. And today we have grown to be a big service with 50 faculty and staff. Well, we have also led the world develop the Society for Integrated Oncology and now providing a definition for what integrated oncology. Integrated oncology is a patient-centered, evidence-informed field of cancer care that utilizes mind and body practices, natural products, and/or lifestyle modifications from different traditions along conventional cancer treatments. Integrative oncology aims to optimize health, quality of life, and clinical outcomes across the cancer care continuum, and to empower people to prevent cancer and become active participants before, during, and beyond cancer treatment. So acupuncture is a part of the domain of integrated oncology, and my service as well as others have done a lot of the clinical trials that over time building the evidence base and publish in leading oncological journals. And this research set the foundation to allow acupuncture now become an integral part of supportive cancer care in the United States as well as around the world. So I will present a few examples to show what a benefit of acupuncture is established through clinical trials for cancer survivors. So the first study is a randomized control trial on hot flashes in women with breast cancer. Because women often have to have anti-hormone treatment for their breast cancer, as well as chemotherapy or surgery can remove their ovaries, cause early menopause. So they tend to experience severe hot flashes such as sweating, feeling really hot, and interfere with their sleep, result in fatigue and poor quality of life. So in 2015, we published a paper in the Journal of Clinical Oncology to show that in 120 breast cancer survivors, and we randomized them into 4 arms: electroacupuncture, sham acupuncture, gabapentin, a standard medication for hot flash, and placebo pill. As you can see, at the end of the 8 weeks, the electroacupuncture had the best reduction in hot flashes, followed by sham acupuncture, gabapentin, the medicine, and placebo pills, with a P of 0.001. So clearly highlighting that electroacupuncture can be very helpful for managing hot flashes. What is also very interesting is that the acupuncture group has much lower rates of side effects than the medication group. So not only acupuncture is effective, but also associate less side effects for women with breast cancer. But really interestingly, we then follow people for 4 months without use of acupuncture or medication. We actually found the reduction in hot flash only strengthened over time with acupuncture. So is sham acupuncture and placebo pills. But on the other hand, the Western medications, when you stopped the use of the medication, the hot flash actually got worse. So the effects reduced. So clearly show that acupuncture not only causes short-term improvement in hot flash, but also that effect is very durable over time. On the other hand, Western medicine can mask the hot flashes, but may actually interfere with the natural healing or regression of the symptoms over time. So clearly demonstrating that for symptoms of a hot flash in women with breast cancer, the ideal way probably is using non-pharmacological treatments such as acupuncture rather than using a medication to suppress it. This last year, we published a study in Journal of National Cancer Institute on a comparative effectiveness trial of acupuncture versus cognitive behavior therapy for insomnia. As many of you may know, insomnia or sleep disturbance can affect up to 60% of the cancer survivors, in part because the anxiety associated with the cancer diagnosis, as well as the many treatments such as steroid patient getting during chemotherapy and cause short-term sleep disturbance, and over time can lead to chronic insomnia. In this trial, we randomized 2 people to either acupuncture, that's the orange line, or the cognitive behavior therapy, that's the blue line. For those of you not familiar with CBTI, it's a therapy that focuses on using structured advice to change behavior, as well as change the cognition around poor sleep. It is considered a gold standard in sleep management. But here we show that acupuncture resulted in a clinically meaningful reduction in insomnia. However, it's less effective than CBTI. But both treatments resulted in very durable treatments, i.e. after 4 months without additional treatments for both CBTI and acupuncture, the benefits for their insomnia symptoms persisted. But then when we focus on people with pain greater than or equal than 4, we found a very interesting results. Is acupuncture have almost identical results as CBTI for managing insomnia. But acupuncture may have better response for pain, which is 55% people will have clinical response for pain reduction versus CBTI. So suggesting in cancer survivors with pain, actually acupuncture can not only be the best treatment, but it's really a treatment not only address insomnia, but at the same time address pain. So clearly, I think we are showing that with insomnia management, one size does not fit all. Acupuncture can potentially play a really important role in managing pain and comorbid sleep problems. As many of you may know, chemotherapy can often cause tingling and numbness in the hands called chemotherapy-induced peripheral neuropathy, also called CIPN. It's a very difficult condition to treat. The only medication is found effective is called the duloxetine. It's an antidepressant. But the effect is very mild, and it has a lot of side effects. A lot of patients don't tolerate it. This side effects cause a lot of cancer patients stop chemotherapy prematurely, which can negatively impact their survival. And it can also cause cancer survivors to fall, which affect their functions and mobility. Here in the phase 2 trial, my faculty, Dr. Bao, and I conducted a trial that randomized people to electroacupuncture, sham acupuncture, and usual care. We randomized 75 people with moderate to severe CIPN symptoms. And the results were published in the JAMA Open Network earlier this year, where we see this panel is for real acupuncture. So compare with the baseline of 4.15 for pain, the acupuncture reduced pain by 1.75, which is a 0.05 significant. And for tingling and numbness, also reduced significant improvement. So you can say real acupuncture in this single arm setting resulted in pre-post reduction in pain, tingling, and numbness. However, for sham acupuncture, the only improvement is in numbness. But for pain and for tingling, it didn't really produce as impressive results as acupuncture. So what it does tell you is that there is likely a potential benefit for real acupuncture over sham acupuncture for improving CIPN symptoms. So because this is a phase 2 trial, our primary goal is not to establish statistical significance, but establish a signal so we can design a well-powered, adequate control trial. We just learned that we got a very good score for a large grant, including about 250 breast cancer survivors. So that's the next study we're planning to carry out to take this pilot study to a definitive phase 3 trials. And another study is that Dr. Ding, a faculty in my group, and I studied how acupuncture can be embedded in the bone marrow transplant for patients with hematological cancer. Here in blue line, you see, for this type of patient, they get high-dose chemotherapy, cause acute rise in their symptoms, and then they get bone marrow transplant, and then it takes a long time for their symptoms to return to normal, 30 days after the initial conditional chemotherapy. So during this period of time, people suffer a lot. Often they are very sick and remain hospitalized. So nowadays, there's a gradual movement to move the bone marrow transplant to an outpatient setting. So we tested whether we introduce acupuncture can help to prevent the symptom increase. In this pilot trial of 63 people, here's the red line is the sham acupuncture, green line is true acupuncture. We found a very interesting descriptive curve to show that the real acupuncture may completely flatten the symptom curve, actually make people feel better than at baseline, which sham acupuncture also seemed to be helping to reduce this overall symptom burden. Clearly suggests that there's quite a bit of symptom distress is likely to be associated with the psychological fear of the symptoms. So having the process of acupuncture may be very beneficial. But on top of that, specific needling can offer additional benefit. And not only that, we found that the specific benefits, particularly when real compared with sham, is in the areas of nausea, appetite, and drowsiness, as well as compared with sham, real acupuncture is shown to be reducing the number of opiate use. So this is very intriguing because in the United States, there's a very substantial opiate use for cancer patients. And when you use a lot of opiates, you can have drowsiness, you can also have poor appetite, and sometimes it can cause nausea. So our hypothesis is that acupuncture can act as almost a non-pharmacological opiate to help prevent pain and improve symptoms. So currently we're doing a multi-center trial involving 300 patients going through bone marrow transplant. So in about 2 to 3 years, we will bring very definitive data to hopefully demonstrate the benefit of acupuncture embedded in bone marrow transplant patients for people undergoing this very symptom heavy procedure. This is the newest findings from our study just presented in June. We're currently writing up the paper. So in this study, we randomized 360 cancer survivors with chronic pain. So as you know, many of the surgery, radiation, chemotherapy, and hormonal treatment can cause a variety of joint and musculoskeletal post-operative pain. So what we did is we randomized 360 patients, any type of cancer, to electroacupuncture, body acupuncture with low-dose electricity, and battlefield acupuncture is auricular acupuncture with 10 standard points. And then another group is usual care group. This group people can get medications or physical therapies. So we found over time, at the end of the 10 weeks, and both treatments cause significant benefit for pain reduction. Here's the number. So EA reduced the BPI pain intensity by 1.98. That's about a 0.91 standard mean effect, which is considered a large clinical effects. And BFA is 1.5, translate into 0.78 effect size. That's a moderate large effects. So this is the largest clinical trial being conducted in cancer survivors for chronic musculoskeletal pain. We hope with this study we provide definitive evidence for the effectiveness of acupuncture for managing the symptoms. And as a result, we hope to change the insurance coverage to allow cancer survivors to have access to acupuncture for chronic pain management. So based on the work we and others have done over the last 20 years, National Comprehensive Cancer Network clinical guidelines, this is the clinical guideline group developing clinical guidelines for oncologists, not only in the United States, but also in the world, to managing cancer patients. At least 5 out of 11 guidelines endorse the use of acupuncture for pain, for fatigue, for nausea, vomiting, to be used in palliative care setting, as well as to be used in survivorship setting. So it is only possible with rigorously conducted clinical trials, we're able to allow the clinical evidence to be recognized by our conventional medicine colleagues and really make it part of the standard cancer care. As you can see in the United States, between 2009 and 2016, the number of participants of NCI designated comprehensive cancer center, these are leading cancer centers. There are about 60 of them in the United States. So the amount of them from increasing the provision of acupuncture increased from 58% to 89%. That is really essentially every large comprehensive cancer centers endorsing the use of acupuncture for symptom management for cancer patients. And this is a slide showing here at MSK. I became the service chief about 5 years ago. In the short 5 years, we have expanded acupuncture in 7 different locations, and allowing our clinical volumes has increased from about 2,000 to 7,000. So this can only be possible because our oncologists are recognizing acupuncture as an evidence-based symptom management strategy and working with us to make the care for cancer patients more holistic. In order to make acupuncture more available for cancer patients, We also developed an online education program for community acupuncturists. So this provides the CEO hours, and so far close to 500 community acupuncturists from many different countries have participated in our course and learn how to administer acupuncture safely for cancer patients, as well as how to communicate evidence to their conventional physician colleagues to build their clinical practice. So November 6th and 7th at MSK, we're hosting a virtual symposium in partnership with SAR. And this is going to go much more in depth. It's about 2 days. We're going to cover cancer pain, fatigue, insomnia, as well as cognitive functions and gastrointestinal symptoms, as well as the neurophysiology of acupuncture. We're also going to bring some international perspectives, as well as address the issues of building successful acupuncture clinical practice, as well as educate other acupuncturists about oncology acupuncture. Here's a website you can find out about registration. You can Google MSKCC Oncology Acupuncture. Last, I want to leave this slide. This Kiom Sar conference has been a huge success. It's testament of a global collaboration between our amazing Korean acupuncture researchers and our SAR leadership and member. In 2021, we'll be hosting a conference in the beautiful University of Michigan Ann Arbor campus. It's called the Pandemics, Pain and Public Health, Roles and Relevance of Traditional Eastern Asian Medicine. We hope to see all of you there to continue our dialogue on how best to use research to advance the care of acupuncture for our global patients. As our world experiencing an unprecedented pandemic, as well as many epidemics of chronic diseases such as heart disease, women's health issues, cancer, and diabetes and obesity, I do think acupuncture plays a huge role in promoting health, addressing symptoms, and help people to live a better and healthier life. Thank you so much. I really appreciate your time and attention.
Thank you, Professor Mao, for your insightful presentation about oncology acupuncture. Next, I would like to invite Professor San-Wi Su. Professor San-Wi Su is an associate professor and the chief of the unit of traditional Chinese medicine, gynecology, and pediatrics in China Medical University. Currently, she also works as one of the project conveners for the project of health insurance pilot project of pregnancy and childbirth management using Chinese medicine. Okay, Professor Su, are you ready?
Yes, I'm ready.
Okay.
Can you hear me?
Okay, very nice.
Yes.
Yeah.
Okay.
Yeah, please
Okay,
start.
let me start my presentation.
Yes, please.
Yes, okay. So can you see my slides? Let me share my slide with you. So can you see my slides?
Yes, we can.
Yes, okay. So let me start. Today, my topic is about a pilot project about pregnancy. It was held by Taiwanese government. And this project is a pilot project, and it's about pregnancy and childbirth management. Okay, next. The purpose of this project. It's our government is encourage childbirth. It's a very important policy here in Taiwan. And the main purpose of this project is to increase successful childbearing in infertility female and males. and as well as the frequent miscarriage women, by providing the service of traditional Chinese medicine. And actually, this whole project can be divided by 3 sub-projects. The first sub-project is for female infertility, and the second is for male infertility, and the third is for miscarriage prevention. So the first sub-subject for female infertility. So the female going into this project need to meet the criteria of infertility. She need to have been married for more than about 1 year. And for women less than 35 years old, the time failure to conceive after 12 months regular intercourse without contraception. But for female more than 35 years old, the time period of 12 months is reduced to 6 months. And for male infertility, so after married for 1 year, and his wife can fail to get conceived, and the male check his semen, the male have abnormal semen test result. And for third sub-project, is a miscarriage prevention. For female have signs of threatened abortion, and or the female is not conceived naturally. And for female, she has frequent miscarriage. It means she has miscarriage for more than 2 times. So she could go into this project before 20 weeks. And in this project, because it's a national health insurance project, the medical records need to be recorded into the chart, and the chart, the government would collect the information of the chart. So the medical record, all in these 3 sub-project, information from the 4 diagnosis method of TCM need to be recorded in the chart. So including inquiry, pulse palpation, tongue, inspection, and listening, the 4 diagnosis methods, the results need to be recorded in the chart. And then for female infertility, the chart need to record information of her basal body temperature and some history of Western medicine intervention. Has she been received some treatment of IVF or IUI or the ovulation induction? All the past history of Western medicine need to be recorded. And in this sub-project, TCM constitution need to be recorded in the chart. And for male infertility, the result of semen examination need to be reported. And for miscarriage prevention sub-project, the information of miscarriage signs, especially abnormal bleeding or uterine contraction, need to be recorded in the chart. And in this project, we ask doctors to give health education information. If a doctor gives instruction of ovulation day to the woman, he needs to record the content of health education information in the chart. And the doctor might suggest some nutrition for pregnancy. And more, the doctor may suggest some food suitable and unsuitable according to TCM to the woman who want to get pregnant. So all this health education information need to be recorded in the chart. And the chart need to include herbal medicine, the content, the formula or single herb, the herbal medicine into it. If the patient receives acupuncture, the doctor needs to record the points or electroacupuncture information into the chart. And then this is the government budget for this project. We have been conducting this project for more than 4 years. So in the first year, 2015, the budget is 32 million, but the executed budget is only 24.7 million. So the executed rate is about 77% of the budget. This is the beginning, the first year. And then in the second year, 2016, because of the propagation, many Taiwanese population, they knew this project, and more clinics, they know this project. So the executed rate increased substantially. So in the second year, the executed rate is 171. Actually, it's over budget. And then the third year, because the second year it's over budget, so the third year the government gave more budget for this subject. So the government in the third year gave TCM 47.7 million for this project. And then the executed rate is more than 131%. And then, so the fourth year, the government gave more. So the first year, the government gave 60 million, and the executed rate is still higher than 100%. So this is the clinic number and patient number and the fee for the whole project. So in the first year, 2015, the clinical number is 89 clinics. The doctor number involved in this project is 157. And the patient time, it's about 23,000. The patient number is 7,000. And the reimbursement points is about 24 million. But in 2018, the clinic number going into this project is more than 100 clinics. The doctor number is almost 200. And the reimbursed points reach 67.9 million. And the total, the 4 year in total, in this 4 year, the reimbursement points is about 210 million. So this is an average. The average number this project cost 52 million. So this is the visit number. In average, each person in this project visit the clinic for 7 times, seven visits. So the patient may go to the one clinic for seven visits in average, and in the beginning. But more and more in the last year, each patient visit the clinic, it's almost 10 times. And in each visit, the fee cost, in the beginning is 1,062. In the last year, it's 1,100. And average fee per patient is about 9,000 this is it's almost 10,000. It's Taiwanese dollars. And we can see the result of this project. This is in years and in areas. According to Taiwanese health insurance project, the Taiwanese health insurance divided the whole Taiwan into 6 regions. The 6th region is Taipei region, North region, Middle region, South region, and Kaohsiung region, and East region. So in this 6th region, we can see in the first year, the Middle region have the highest pregnancy rate. The pregnancy rate is 16%. And in the second year, North region have the highest, but the Middle region have the second. It's almost 23% pregnancy rate. And then in the third year.
Can you hear me? Yeah, sorry, your presentation slide fixed it medical record part, so can you match with your talk and slide number?
Sorry, do you mean I need to?
Please.
So what's the problem?
Would you please? The slide number is not matched with your talk.
Oh, sorry.
Yes.
So
yeah.
Okay. So let me go to the next slide.
Okay.
Oh, sorry. So.
Okay. Thank you so much.
Okay. It's okay. So this is the pregnancy rate. Pregnancy rate of the whole Taiwan. Also, the Taiwan we have 6 areas, and the first year the Kaohsiung area have the highest pregnancy rate, and in the second year the North area have the highest pregnancy rate, and then in the third year the Middle area have its have high pregnancy rate, and in the last year the Middle area still have the high pregnancy rate. So the pregnancy rate, we can see it's varied from 11% to 23, about 23%. So this is the pregnancy rate in years. And so total, we see the whole Taiwan, the pregnancy rate is about in 16 to 20, about this number. So the pregnancy rate in areas, in the middle area of Taiwan, we have the highest pregnancy rate. And then we can see the constitution for the infertility women. So the constitution, we divided all constitution into 9 constitution. We use the 9 constitution method. So the 9 constitution are those constitution of TCM. The first is neutral, is harmonized, neutral constitution. And the second is Qi deficiency constitution. And then Yang deficiency, Yin deficiency, flame wetness, wet heat, prostasis, and spatial dialysis, and Qi depression. So we can see from among these all the infertility women, Qi deficiency is the highest constitution. And then the second is spatial dialysis. The third is Yang deficiency. So Qi deficiency, spatial dialysis, and Yang deficiency, these 3 constitutions are the most commonly seen constitution among infertility women. And then in the miscarriage prevention sub-project, we can see miscarriage prevention rate It is calculated by the case number with gestation age last more than 20 weeks. It's divided by total case number. So the miscarriage prevention rate in this project is quite high. It's in the first year, the whole miscarriage prevention rate is about 66, and then in the second year it's about 80. The third year is 76. The first year is 68. So so in this miscarriage prevention rate in these years, we can see the whole this is the whole Taiwan condition, and then we can also see the prevention rate in areas. So in among these 6 areas, the north area have the highest miscarriage prevention rate, and then the second is the south area. So in the whole Taiwan, the average miscarriage prevention rate is about 73%. So the last slide talks about our future work, because this is still a pilot project. So we are still looking for some method to improve this project. So since the second year, the project is always over budget. So now we are thinking about control the case number. So we plan to change some including criteria for patients. We want it to make it more strict, and moreover, we are going to ask the government more budget. And for the low pregnancy rate, we are not satisfied with the 16% pregnancy rate. So we are going to modify inclusion criteria, and we are going to educate our TCM doctors to improve their skills in the infertility, to treat the infertility, to improve, to make the pregnancy rate higher. And we are going to let more Taiwanese population to understand, to know this project. So we are going to improve the publicity, because when we see the regional number, the north and the south, the east, it's a very big regional differences in case number. So we are going to improve to propagate this project, to let more population they can understand, they will let them know it. Okay, thank you for your attention. I'm very appreciate.
Thank you, Professor Su. Very nice talk. Your talk about use of Chinese medicine for pregnancy and childbirth management in Taiwan is very well matched with Professor Dong-Il Kim's presentation. Now I would like make the last presentation by me. The title is National Health Insurance Coverage of Chuna Manual Medicine through Effectiveness and Economic Evaluation. Let me introduce myself. I'm Professor Byung-Chul Shin, and I'm working at the School of Korean Medicine, Busan National University, and working at the Spine and Joint Center in Korean Medicine Hospital as a clinical professor and a clinical researcher. Slide, please slide. My talk on today is National Health Insurance Coverage of Tuna Manual Medicine through Effectiveness and Cost Evaluation. I prepared two parts. One is a brief introduction to National Health Insurance Coverage inclusion process of Tuna Manual Medicine, and the next part is evidence on the effectiveness, safety, and economic evaluation of Tuna Manual therapy. The aim of this presentation is to introduce how Tuna Manual therapy was covered by the National Health Insurance coverage through the effectiveness and economic evaluation in Korea. And the next aim is to present the current evidence on Tuna Manual therapies by the systematic reviews and randomized control trial. What is Tuna Manual therapy? Tuna Manual therapy is deeply rooted in traditional Korean medicine, also same roots with Chinese, traditional Chinese medicine. It is very well matched with each other, but Korean style Tuna manipulation is not massage, but more related to medical manual therapy with diagnosis. Tuna manual therapy was classified three categories. Simple include joint mobilization and myofascial release technique, and joint distraction techniques. Complex category include joint manipulation. Generally, it accompanied with joint click sound, and special part is include joint dislocation reduction technique, visceral manipulation, and craniosacral therapy. It's a very whole picture of process of National Health Insurance coverage inclusion of Tuna Manual Medicine. Three parts was very actively push this process to the government and work together each other. One is the government side. Government, they include the plan for midterm plan for pushing the Tuna Manual therapy to include the health policy. And the other part is Association of Korean Medicine. They very closely working with the Korean Society of Tuna Manual Medicine and with the government side. And they published evidence report on Tuna Manual therapies. And the government make the fund for the research for Tuna Manual therapy evidence from 2016 to 18, and they launched a pilot program of Tuna Manual therapies for the inclusion of National Health Insurance coverage. And then the last year, finally, the Tuna Manual therapy was launched to National Health Insurance coverage. Tuna Manual therapy is a major component of Korean medicine treatment for spinal disorder, was covered by the Korean National Health Insurance at the last year, April. And the next part is evidence on the effectiveness, safety, and the economic evaluation of Tuna Manual therapies. Before the inclusion of National Health Insurance coverage of Tuna Manual therapy, the government required two parts. One is evidence on the effectiveness, safety, and the economic values for making health technology assessment. And the second requirement was the standardization of Tuna Manual therapies. The government's funded research project from 2015 to 18 was conducted with the objective of establishing clinical evidence for tuna manual therapy in Korea. The aim of this funding is to create the evidence on the effectiveness and safety and the economic values of tuna manual therapy from the systematic review and the clinical trial. Firstly, as I'm a principal investigator on this project, so we firstly composed the tuna research network with 2 academic society and 2 university hospital and 2 spine specialty hospital for making evidence. It's it's a summary of the project. The first year, stage 1, where we firstly conducted a systematic review on the evidence of the effectiveness and the safety and the economic values, and we composed a pilot trial. Then we make the multi-center clinical trial. Let's look at the evidence from the systematic review. We make a report on evidence and then publish many pilot trial or randomized control trial or systematic review. Yeah, firstly, we conducted evidence on the effectiveness. We searched the total 28 systematic review and the total 778 randomized control trial was searched, and we analyzed. After then, we know the musculoskeletal area is the most researched area, and followed by the pediatrics, and the next one is neuropsychiatric and the gastrointestinal problem by the randomized control trial. After then, we select only well-randomized control trial on musculoskeletal condition, and after then, we found 66 randomized control trial on musculoskeletal conditions. It's the summary of the effect estimate of tuna manual therapy for pain and function on musculoskeletal condition. And first, the outcomes was pain by the BAS or NLS, the tuna manual therapy compared to sham by 1 trial, and CMT versus traction was 9 trial, and the compared to physical therapy by 3 trial, and the drug compared to drug was 5 trial. Next one is the outcome from functional disability. All generally, most of all outcomes show the better improvement compared to control groups. It's the summary of the assessment of Cochrane risk of bias from 66 randomized control trial on musculoskeletal condition. As you can see, we only selected a well-randomized control trial, so the random sequence generation was a low risk. All show the low risk of bias, and the allocation constraint was almost 25% were conducted. And as you know, manual therapy was very hard to be blinded by the practitioner or participants. So the result was generally high risk of bias, and only very few percent of randomized control trial were blinded by the assessor. From the systematic review, the systematic review of 66 randomized control trial demonstrated that tuna manual therapy may have a favorable effect on pain and function disability caused by the skeletal condition. Now look at the safety on tuna manual therapy. We also conducted a systematic review. We found 5 systematic reviews, 29 randomized control trial, and 9 case series, and 35 case report. We analyzed that. Most of all the problem came from neurological condition and the vascular problem and the connective tissue disorders at cervical spine and lumbar spine. 47 adverse reaction from 78 literature paper were identified, but some are serious, some are not. It's an annual consumer report from 2015 to 18. Tuna manual therapy occupy 2.95% of total medical injuries in Korean medicine. It's a 4-year statistic from Korea. The next slide is economic evaluation on tuna manual therapy. We also do a systematic review. Then the report was we found 18 reports. And then the four papers, they report dominant. Dominant means less costly and more effective. And 7 papers reported cost effectiveness, and also 7 papers also reported not cost effective. Now look at the evidence from the clinical trial. Firstly, we conducted a pilot trial, firstly, and then we compared 3 arms. One is a tuna manual therapy group, the number was 20, and the other group was a usual care group, the number was 20, and the tuna manual therapy plus usual care group, the number was 20. Also, we after we conducted the pilot trial, we can conclude this is a pilot preliminary study, so well-powered randomized control trial can be the sample size can be 192 participants, and the 2 group comparison is very reasonable for the next multi-center trial. So we conduct a multi-center trial for non-acute low back pain, and we allocated 2 groups. One is a tuna manual therapy with the usual care group, and then the control group is usual care only group. Usual care generally include the analgesic drug and the physical therapy or other therapy. Generally, it's called usual care, and we included 194 participants and randomly allocated to either CMT plus usual care and or usual care alone. The number was 97 to 97, and the primary outcome was the numerical rating scale, pain rating scale on low back pain. It's the result from the randomized control trial. The change of pain intensity by the analysis of low back pain and function by Ost-West disability index in each endpoint. The primary endpoint was at 7 weeks trial. After 12 weeks, we checked the follow-up check. As you can see, the usual care plus tuna manual therapy group show better reduction on pain and better improvement in function by the OSWA3 disability index. From the randomized control trial, the 21 adverse events were reported, but it was generally minor to moderate, and no statistical significance difference between two groups. And it's a result of economic evaluation. The ISO reported 9,248 US dollar by the EQ bus, and 22,961 US dollar by the EQ5D. Generally, it compared to its own country's GDP. And so Korean GDP generally reported over 30,000 US dollars. So the Korea government can burden its cost effectiveness. So it showed cost effectiveness. Now I would like to summary of the evidence. Systematic review have shown that musculoskeletal conditions are the most clinically researched area, and tuna manual therapy displayed improvement in pain and function from 66 randomized control trial on musculoskeletal condition. Randomized control trial showed that tuna manual therapy presented comparative effectiveness and cost effectiveness in non-acute low back pain compared to usual care alone. And the safety was generally good, but at the systematic review report, there is some report on the vertebropatellar insufficiency attack, or the Cauda-Equina syndrome. Is a very severe condition. And economic evaluation, it shows cost effectiveness. Also, the government also they required some other very important factor to before the national health insurance coverage inclusion. And one is a standardized practice guideline is very essential. Last year, the Korean Society of Tuna Manual Medicine with Korean Association of Korean Medicine, they published practice guideline last year, and standardized the textbook is very important. It's the textbook on tuna manual medicine to all university education, and also require the standardization of educational requirement and the practice. The Korean Society of Tuna Manual Medicine, they follow the FIM guideline. FIM is the Federation International Manual Medicine. They published that guideline, and then the Korean Society, they follow the guideline. It's the last slide of my presentation. The importance of tuna manual therapy inclusion to national health insurance system is the first traditional medicine modality by the method of conventional health technology assessment analysis. And for the inclusion, we reported many clinical evidence on effectiveness, safety, and economic values. And we reported to the government the definition of tuna manual therapy standardized procedure, and we we did calculation of RBRBS. RBRBS is a resource-based relative value scale. It's a very formal process for inclusion of national health insurance coverage. Thank you for your attention. Okay, now we move to the Q&A session. Thank you everyone for your attention, and I would like to invite all speakers again for the Q&A session. Let me ask some question from participant. Okay, we have three questions. To Professor Jun Mao have two questions, and one question is to Professor Su. I will read the question. First question. What indications do you think acupuncture have the sufficient magnitude of efficacies in cancer patients compared to the standard cares, and how many? I mean, not simple symptom, but syndrome or disease. Okay, Professor Mao, would you give the answer to the questioner?
Thank you for the question. I think what I feel like whereas acupuncture have really clear evidence for cancer is symptom management. When it's nausea, vomiting, that has been around for about 10 years. And I think for hot flash management in women with breast cancer on endocrine therapies, and for pain management, I think that evidence is accumulating. I think the evidence is robust enough. Those are, I think, I would say either grade A or grade B evidence. And then there's several other areas I think are emerging level of evidence are for sleep, insomnia, for fatigue, as well as for CIPM. So those I think require some additional trials to increase the evidence base.
Okay, thank you. Thank you very much. And another question on to Professor Mao. I will read that. Excellent talk, Professor Mao. Very inspiring. Thank you very much. With the increased evidence supporting the use of acupuncture in oncology, what are the barriers and enablers to widespread adoption of this therapy, and what are the strategy for moving forward?
That's a great question. I think in countries like United States or Western countries, I think insurance coverage is one of the biggest barriers. I think across the globe, including in probably Korea or in China, I think adequate communication, dissemination of the evidence base of acupuncture to both patients as well as oncologists are really important. No matter how much research we do, but if oncologists or oncology nurses are not aware of those evidence, they're not going to refer. So I think really creating bridges to building bridges between the acupuncture research community or acupuncturists and conventional oncologists or oncology nurses, I think are really important to remove the barriers for our patients.
Okay, very nice answer. And his talk is to the insurance coverage is very important, and the condition from the doctors and nurses and the other members are very well collaborated, is very important factors to the moving forward. And the last question to Professor San-Wee Su, I will lead the question. Dr. Su, thank you for your talk. Is there any type of constitution respond to traditional Chinese medicine better than other types in pregnancy rate and in miscarriage prevention?
Yes, thank you for your question. And I think in Chinese medicine constitution, the most important constitution is qi deficiency. And in traditional Chinese medicine, the theory, as it's shared by the first speaker, Professor Kim, the same kidney deficiency is a very important constitution, or we can say kidney deficiency is a very important pattern that could be measured by traditional Chinese medicine, I mean herbs. So I think it's very similar, the same condition in Chinese medicine and in Korea. I think we think the same. Kidney qi deficiency or kidney yin deficiency, yang deficiency, kidney deficiency pattern are the most suitable constitution for Chinese medicine or for herbs. Thank you for your question.
Okay. Your talk means key deficiency is the key constitution of the miscarriage or other problem, the pregnancy. Can you explain some how was the key deficiency styled? Because of many international research may not know the key deficiency condition. Can you introduce some thin body or very tired or something like that? Yeah.
Okay. Thank you. Key deficiency, it is diagnosed by traditional Chinese practitioner using some signs and symptoms. Like signs is including the person, you feel the person, she speaks weak, she have low voice, no energy, no strength. You can observe the signs. And in Chinese medicine, it's very special to take the pulse, and the pulse, if it's weak, we will say it's key deficiency. And symptoms, key deficiency symptoms, the patient will feel very tired always. She cannot walk for a long distance, or she cannot do her job for a long time. Maybe she go to office and do her work. Other people can do 8 hours, but she do 4 hours and she feel tired. So tiredness is a very important symptom to diagnose qi deficiency. So that's about how TCM practitioner to diagnose qi deficiency.
Okay, thank you very much. We can imagine the feature of qi deficiency. We have one more question to me, the Professor Shin. Thank you for your excellent talk. Could you please explain the Korean National Health Insurance Scheme and what are included and the reimbursement process? Yes, thank you. In Korean, National Health Insurance Scheme is divided by the 3 parts. One is medical, conventional medical part, and the other is the dental part, and the Korean medicine part, and also the last one is the drug pharmacy part. So in Korean medicine part, we include the national health insurance system covered the acupuncture and the cupping and the moxibustion and some 56 herbal medicine for diverse condition. And last year the Chuna manual medicine therapy was covered by the National Health Insurance coverage, and it's based on the evidence on that modality. We should report it to the government for it is beneficial for the people in Korea, and the general reimbursement scheme was 30% the patient should pay for them, and 70% the government generally covered the total covered that portion of total amount. Okay. Okay, we don't have any any more questions, and so thank you for all speakers and participants. Now let me close plenary session 5. Thank you very much for all participants.
Now, that concludes the last plenary session. I'd like to thank all the presenters and the chair. You may leave the stage now. It's time for the closing ceremony of Kiom SAR 2020 International Research Conference. Distinguished guests, ladies and gentlemen, good afternoon. I am Harim Seo from Kiom, and I'm pleased to host this closing ceremony today. We had more than 2,000 participants from 56 different countries around the world for the Kiom SAR 2020. And I can say that this is an unprecedented number. It is regrettable that we couldn't meet all the participants face-to-face due to this COVID pandemic. But I'd like to say that this year's conference was very innovative and successful for having this many participants thanks to the internet and the ICT technology. At this conference, in addition to the official programs, we have prepared a special program for Korean medicine college students. I hope this program could help them to explore various future paths as the talented of the Korean medicine down the road. And now, I have the honor of opening the closing ceremony. The closing ceremony will start from the award presentation, closing remarks, and the announcement of SAR 2021 conference. First, 3 presenters will be awarded with outstanding oral presentations, and the Rising Researcher in Korean Medicine Award will be given, which is a joint special award prepared by Kiom and the Society of Korean Medicine. Now, it's time to announce the awardee who graced this conference with outstanding oral presentation. President Kim Jong-yeol of Kiom, the co-chair of this year's conference, will announce 3 awardees. Ladies and gentlemen, please welcome President Kim with a big round of applause.
Good afternoon. I'm Kim Jong-yeol, President of the Korea Institute of Oriental Medicine. I'm really amazed with all the excellent presentations for the last 3 days. I would like to express my sincere gratitude to all the fellow researchers who have energetically attended, presented, and discussed in the conference. More than 150 abstracts were submitted for the conference, and 11 abstracts were orally presented. Now is the time to honor the best outstanding presenters with awards. Among 11 presentations, the evaluation board chose a remarkable one in basic science and 2 outstanding ones in clinical science. Now, let me announce the winners of the awards of Kiom Sar 2020 on behalf of the organizing committee. First, the winner of Outstanding Senior Researcher Award in Basic Research is Dr. Harrison Fisher. He identified the role of brain connectivity in the effect of acupuncture in carpal tunnel syndrome. It has significant impact in acupuncture research. Congratulations. Next, the Outstanding Junior Researcher Award in Clinical Research goes to Dr. Choi Yu-jin. She presented the significant result of a pilot study on mild cognitive impairment and the comparative effect of electroacupuncture. Congratulations. Lastly, the winner for Outstanding Senior Researcher Award in Clinical Research is Dr. Lee Ye-sil. She conducted a systematic review on reporting of the placebo sham intervention in clinical trials of acupuncture. It has not been evaluated thoroughly before. Congratulations. I would like to heartily congratulate all the winners. I hope those selected research outcomes will contribute to strengthening solid foundation for further study and clinical practice. Congratulations again with a big applause. Thank you.
Thank you very much. My sincere congratulations for all the awardees. The award and gifts will be delivered by mail safely. The next award is the Rising Researcher in Korean Medicine Award. We have chosen 2 researchers, and the President Choi Do-young of Society of Korean Medicine will honor the first awardee. Please welcome President Choi.
안녕하십니까?
Ladies and gentlemen, my name is Choi Do-hyun, the president of the Society for Korean Medicine. First of all, I would like to congratulate you on the successful opening of the Kiom Sar 2020. And I am honored to present the Rising Researcher in Korean Medicine Award. And I hope that this award can contribute to the emerging researchers in the field. So the first winner of the award is Professor Kim Min-jung. Congratulations. Professor Kim Min-jung is from the College of Korean Medicine, Seongji University, and she has been participating in various research areas. And I hope that this award can contribute to your future researches. Once again, congratulations to Professor Kim Min-jung.
Thank you very much.
네, 감사합니다.
Let me invite President Kim again for the second awardee.
화면이. Thank you. Again. As you know, motivating young researchers is essential in every academic field, and the conference takes place in Korea. So, Kiom Sar 2020 conference is the right place to motivate young Korean researchers. Therefore, we have prepared the Rising Researcher in Korean Medicine Award, jointly with the Society of Korean Medicine. The prize could be a reward and motivation for junior Korean researchers who is developing their career in traditional medicine research. The second winner of the Rising Researcher in Korean Medicine Award is Dr. Im Jung-tae. From the Society of Internal Korean Medicine. Dr. Lim is a promising researcher who is substantially contributing to the establishment of scientific evidences for Korean medicine through systematic reviews, development of clinical research protocols, and implementation of clinical research. Congratulations on your award. I hope you will continue your effort for the future Korean medicine.
Thank you. Congratulations to all the awardees once again. Now, President Kim will deliver the closing remarks. President Kim, please.
Good afternoon, distinguished participants. The Kiom Sar 2020 International Research Conference has come to an end. After 3 days of passionate presentations and heated debate, I would like to express my deep gratitude to the 16 keynote speakers and oral or poster presenters. We have shared their outstanding research outcomes and clinical experiences through various symposia, workshops, oral and poster presentations. I also sincerely appreciate all participants who actively contributed to the successful Kiom Sar 2020. We were unable to meet face-to-face, but we could exchange novel findings, ideas, and insight better than ever through the virtual conference. The Kiom Sar 2020 introduced a new format of communication and traditional and integrative medicines. With the help of virtual conference, we have envisioned together the future of traditional medicine under the theme Bridging East and West from acupuncture and traditional medicine research practice. Through this conference, we could reaffirm the great potential of traditional medicine and its immeasurable value as a future medicine. At the same time, we know where the challenges or difficulties confronting traditional and integrative medicine. Therefore, continued efforts should be made for standardization, scientific research, and evidence building in order to bridge research outcomes and clinical practice, deliver the outcomes to policymakers, and eventually link them to clinical health care. This cannot be done by an individual or a single organization. It is a dimension beyond the endeavor of a single entity. It requires close cooperation between all engaged actors. My respected colleagues, the Kiom Sar 2020 conference ends today, but I hope you all remember the knowledge, brilliant ideas, and warm friendship that we have shared in this conference. The Korea Institute of Oriental Medicine will keep cooperating with research institutes and societies in traditional medicine, and will prepare for another Kiom Sar 2020 as a site for future research gathering. I wish you all good health and wish the best for your families and organizations. I hope that we'll meet face to face in the next 2021 SAR conference in United States. Thank you very much.
Thank you very much for your thoughtful words. Ladies and gentlemen, please give him a big round of applause. Next is closing remarks by Professor Richard Harris, the co-president of SAR and the co-chair of the Kiom SAR 2020. He will also make an announcement about the next year's SAR conference. Please welcome President Harris.
Hello, this is Rick Harris. I'm one of the current co-presidents for the Society for Acupuncture Research. I want to welcome you to this concluding ceremony for the highly successful Kiom Sar 2020 meeting that was held here in South Korea. I hope you enjoyed the content of this meeting and that you've renewed bonds between your colleagues and friends and maybe forged some new ones. As you know, the Society for Acupuncture Research holds many events, such as these, in the US and abroad. And I'd like to let you know that in 2021, the Society for Acupuncture Research will be holding another conference, this time in Ann Arbor, Michigan, from June 16th to June 20th. The title of this conference is going to be Pandemics, Pain, and Public Health, Roles and Relevance of Traditional East Asian Medicine. I hope very much that you'll be able to attend in person, but if you're not able to attend in person, I wanted to let you know that portions of our conference will be virtual, meaning that you'll be able to access portions of the conference from anywhere in the world. It also may be that we hold the entire conference virtual if COVID does not cooperate. Thank you very much for attending this conference, and I hope very much to see you next year in 2021 in Ann Arbor, Michigan, either virtually or in person. Take care.
Thank you very much for your warm words. I'm thrilled that the next year's conference will be held on and offline in Ann Arbor in the US, and I hope all of you and more participants could gather there again. We have come to the end of Kiom SAR 2020, which was held online from September 11th to 13th. This successful conference was made possible thanks to the enthusiastic participation, and I would like to extend my sincere gratitude to all the participants and presenters once again. I wish you all the best and good health till we all meet again at the next year's conference. Now, I would like to officially conclude the Kiom SAR International Research Conference. Thank you very much and have a wonderful weekend. 공식적으로 행사 이제 모두 끝났고요. 오늘 자리해 주신 분들 무대 앞에서 기념사진 한번 같이 찍으시겠습니다. 네, 우리 수건 스태프들도 네, 앞에 나와서 사진 같이 찍으시면 좋을 것 같아요. 혹시 여기 불 좀 조금 켜주실 수 있나요?